Good morning, everyone. I am Oxidis Barbeau, and I am President and CEO of United Hospital Fund. And thank you. Thank you. And it is my distinct honor to welcome you today to our 16th annual Medicaid Conference. So we are delighted that we're able to offer this in hybrid form today. And it's great to see so many of you in person from across the state, and a warm welcome to you to those that are joining us online. And just so that I know where the camera for the web is, at the back of the room. All right, so you're going to see a lot of back of heads, people's heads, but then those of us on the front here welcome you. We are excited for a day of inspiring information about what's top of mind in Medicaid, as you will hear from Amir Basiri, New York's Medicaid Director. Round of applause. Um, You're also going to hear about challenges and opportunities within Medicaid from some of the most pressing issues in healthcare, improving perinatal and child health, and integrating physical health, behavioral health, and social care, as you will hear from our panels and a fireside chat. We're also going to hear from Emma Sando, who's the new Medicaid Director of Oregon's Medicaid program, about what New York can expect in the future of its 1115 waiver. And I'll give more context-setting remarks a little bit later this morning. But today, what I'm going to do is just give a few welcoming remarks. And for those of you that are new to United Hospital Fund, let me just clarify our name. There's nothing united about us. We got no juice over hospitals, and we're not a fund. But what we are is a think and do tank focused on building a more effective and equitable healthcare system in New York State for all New Yorkers, but especially for those that are most disadvantaged. And that's what gets me out of bed every day, excited to come to work. It's a joy to be a part of a team that's really focused on how can we help make our state better. We work towards that mission through research and policy analysis, hosting fellowships and demonstration programs, and convening diverse stakeholders to find common ground for solutions to pressing challenges in healthcare. At UHF, we focus on three critical issues in the health system: access to care, bridging quality and equity, and practice transformation through clinical community partnerships. Since 2005, our Medicaid Institute has been working collaboratively with the state to strengthen and improve New York's Medicaid program through research, policy analysis, and convenings like today's conference. There's tremendous value in convenings like this one that bring together such a diverse group of participants, folks from state and local government, payers, healthcare delivery systems, providers, community-based organizations, academia, philanthropy, policy experts, and Medicaid members. It gives all of us the opportunity to learn, ask questions, provide feedback, and foster innovation to further our collective goal of achieving health equity across New York State. Also, based on last year's success, we've waived registration fees for those joining us online and for some attending in person, including, as an example, Medicaid members, students, and small CBOs. Achieving this goal was only possible because of the generosity of our sponsors, particularly the Commonwealth Fund and Unite Us. I want to give a shout out to our sustaining sponsor, the Commonwealth Fund, a private foundation whose mission is to promote a high-performing healthcare system. Without their ongoing support, we wouldn't have been able to have many of you join us in person today for free. And Unite Us, who brings sectors together through technology to ensure people's needs are met. They've ensured that the cost of the virtual conference were covered as well. So thanks again to our sponsors. We also want to thank Essentra Health for the delicious breakfast and Molina Healthcare, who will provide our lunch. You're going to hear from Commonwealth shortly and Unite Us this afternoon, but I encourage you to visit their websites to learn more about their work. And of course, I want to also give a sincere thanks to our other sponsors, IBM, NISTEC, and Equifax Carasoft. So before we get started, a few housekeeping things before we get started. One, we are encouraging, as always, questions during the sessions today. If you're in person, there are mics in the audience. If you're online, please submit your questions in the chat box. We'll be fielding questions from both locations. We want your feedback. For those of you online, there will be Zoom polls at the end of each session. For those of you in person, you can access the survey through the QR code projected on the slides. And I do really ask you to complete those evaluations because it helps us make this conference as relevant as possible each and every year. And as you see, we are in a new venue this year. And so we want your feedback on how that's been working out for you as well. Two more things, or actually one more thing, and then I'm going to turn it over to our first speaker. So we wouldn't be in 2024 if I didn't take a moment to talk about social media. You can talk about this on LinkedIn at United Hospital Fund of New York. You can also do the same on Instagram. We are at United Hospital Fund, and on Facebook, United Hospital Fund. We will be live tweeting throughout the day on X and likely on our Instagram stories as well. So you can start by following UHF at United HOSP, HOSP Fund on X, and then you'll see a tweet this morning with the conference hashtag UHF Medicaid 2024. So before I talk about setting the stage of why we're here, it is my pleasure to introduce Melinda Abrams. Melinda is Executive Vice President for Programs at the Commonwealth Fund and one of our lead conference sponsors and a consistent supporter of this conference for several years. And I welcome her for a few welcoming remarks. Thank you, Melinda.
Thank you so much, Dr. Barbeau. It's a pleasure to be here. The connection between the Commonwealth Fund and the United Hospital Fund runs deep. It runs for a long time. And I just want to also acknowledge Jim Talon, who was the president of the United Hospital Fund for 23 years. But really what was important is that he was the chair of the Commonwealth Fund Board. He was a member of our board of directors for 15 years. He also established this Medicaid Institute that is the backbone of this conference. So I just wanted to acknowledge Jim. Thank you so much for United Hospital Fund for your leadership as a reliable source of policy research, data analysis, as well as convenings like this one, which enables all of us to have viable options to improve health for all New Yorkers. I also want to thank all the other co-sponsors, including Unite Us, but there are many others this year, which I'm really pleased to see. Dr. Barbeau already mentioned we're a private foundation. We're national in scope, but we are based in New York. And so therefore, we always have a special place and a special fondness for New York. In fact, we are launching later this year, or early next year, a new program that will be focused on New York City. More to come about that. All of you know this, but it is worth repeating that Medicaid is the primary program providing comprehensive health and long-term care coverage for 1 in 5 low-income Americans. In 2024 and the year and 25, so many issues at play that will affect Medicaid coverage, financing, and access, from whether it's the unwinding, whether it's women's access to reproductive health care, the workforce crisis, or meeting the needs, the behavioral health needs of Americans. We're proud to support this conference for a number of reasons, but I'm just going to mention a few. And the first is that it is my strong belief and experience that states are at the forefront of redesigning U.S. health policy, whether it's from coverage decisions to advancing equity or increasing affordability. States are often leading the way on how to do so. And the number one challenge, and I kind of already mentioned this, but one of the main challenges that we've all experienced in the past year is the unwinding due to the unrolling and unwinding of Medicaid's continuous coverage requirements from the pandemics. And so many of the choices that states have made on how to manage that have affected the disruptions in care and the continued coverage. The second reason that we continue to support this is that state Medicaid programs are a key lever to spark delivery system transformation. State Medicaid programs are leading the way in addressing the social drivers of health, integrating health and social services to meet people's basic food, transportation, housing, and safety needs. Also leading the way in helping justice-involved populations re-enter into the community to avoid recidivism. State Medicaid programs have also been leading edge for primary care transformation, whether it's been about payment or behavioral health integration and interprofessional consultation. But as we get ready to dig into a day of statistics and proposed rules and an endless number of esoteric acronyms, which I would encourage you all to avoid, I also want to take a moment to remind all of us that we're really talking about somebody's life. And underneath the data and the proposed rules is the well-being of people, somebody's parent, sibling, partner, child, someone who wants to see a primary care doctor soon when they worry that something is wrong or they just want to make sure that they really are okay, someone who needs access to substance abuse treatment when they need it, someone who needs access to evidence-based medical care when she may want to terminate her pregnancy. And that gets me to our third reason for supporting this conference, which is the power of convening, bringing together diverse stakeholders to advance innovation and to equip policymakers and leaders like all of you with evidence to inform policy decisions. It's our belief at the fund and the fund, that it is that diversity of perspectives, the evidence, and the generative conversations it's really that magical combination that makes this conference, the UHF Medicaid Conference in its 16th year, so special. And that is what we think happens here. So I guess I'll just close by saying I can think of no better organization than UHF to convene us. I can think of no better state in which to have this conversation than New York, since New York, due to its history and its leadership in state health policy and system transformation. And I can think of no better topic than Medicaid, since it is the largest public program and has the greatest promise to improve the health of all Americans and all New Yorkers. And with that, I'm going to turn it back to Dr. Barbeau. Thank you.
Thank you, Melinda, for those energizing remarks. I really appreciate that. And I too want to invoke Jim into the room and, say in large part, the work that we're doing today is because of his leadership at the state level and certainly for 20 some odd years at the helm of United Hospital Fund. So he's with us today. So in setting the stage for today's conference, it's important to reflect that we gather at a time where there's tension, right? The pandemic continues to unwind, and there is tension locally and nationally about what the new normal should be. a pre-pandemic siloed status quo, or a more holistic, equitable paradigm that leans towards hardwiring structural remedies for equity into our collective work of cultivating healthier and more equitable communities. We're privileged to live in a state where the commitment to equity runs deep, and there is an ongoing commitment to working collaboratively. Today, we're excited to focus on opportunities for further hardwiring equity into our health ecosystem from a place that doesn't look at healthcare delivery in a vacuum, but that looks to support the continuum that creates health within and outside of the formal walls of the healthcare delivery system, one that better bridges healthcare delivery, public health, and social services, and as Melinda said, keeps Medicaid participants at its core. You'll hear from Amir as he gives us an update on the Medicaid waiver and the major step forward in creating the conditions that can strengthen the relational infrastructure, the governance, data, and technology between healthcare, public health, and social services in addressing the social care needs of individuals, their families, and their communities. There are a lot of great things that have happened in Medicaid since we last convened, and our panel on coordinating care to advance perinatal and child health through Medicaid will share what that's meant to their practice and what promise future developments in Medicaid may hold for that very important population. For some of you, integrating health-related social needs into physical and behavioral health care is like, what we do every Tuesday. For others of you, it's new. After lunch, we'll hear from one practice that is already integrating physical health, behavioral health, and social needs for Medicaid members within a financially viable model. Dr. Cameron Matthews will discuss how City Block has done it and why providing this type of integrated care is better for Medicaid members. I see this as an opportunity for us to visualize a post-waiver implementation future that's filled with achievable and sustainable ways of delivering care that is not only good for patients, but it's also good for providers. And to close our program, we'll hear from Emma Sando, Oregon's new Medicaid director, about the good, the bad, and the ugly of implementing a health equity waiver focused on addressing social care needs. Oregon's Medicaid program is a little farther along in implementing health-related social needs coverage, and there's lots that we can learn from them. And also, lucky for us, Emma also brings her experience incorporating health-related social needs into Medicaid in North Carolina. So we kind of get a twofer there, which is great. So I hope that I have added to the excitement that Melinda kicked off in her remarks about what we have planned for you today. I hope that I've given you a clear sense of what that arc of the narrative is about where Medicaid is, what we're doing that is taking advantage of what Medicaid has done, what the future possibilities are. And let's not get too excited because there's going to be lots of bumps along the way, but we can learn from others' mistakes and have it go as smoothly as possible. So with that, I want to now transition to introducing Amir. It is my, It is my honor to introduce New York State's Medicaid director, and there are so many adjectives that I could put in front of Medicaid director, but I'm just going to say premier. Amir is a social worker by training and is a tireless public servant. And I've witnessed that up front. After working in the nonprofit sector, he joined our state government 9 years ago, first in the governor's office and then transitioned to the Department of Health in 2019. As I've worked with Amir in my new role, I can tell you all how fortunate we are to have a person with his dedication and integrity leading our Medicaid program. Please join me in welcoming Amir Basiri.
Good morning, and thank you very much to Dr. Barbeau and also Melinda for setting the table so nicely. I am hoping to continue the excitement that they both started us off with, because it is a very, very exciting time for the Medicaid program. And me and our team have been working tirelessly for this moment for several years. So bringing this to life is very special for us. And we see this as a real opportunity to achieve some of the goals that Melinda and Dr. Barbeau shared about a more equitable and effective healthcare system. So I'm going to spend a majority, the entire time actually, on the waiver. There will be no other things other than the waiver. We have been living, sleeping, dreaming about this waiver for the last 3 years. So why are we doing this? What is our vision? What's our goal? I think, Oksiri said it at the end of her comments. It really is, as to boil it down, is to achieve a more equitable and integrated delivery system. That is the goal of this waiver, and it starts with the social care integration. But we're really trying to address some of the challenges that continue to persist. If I looked at the Medicaid director's presentation from 5 years ago or 10 years ago, these challenges would be exactly the same, which is disappointing, but is also energizing in that we have a lot of work to do. And we think that this waiver really brings in a layer that will help bring the ecosystem of partners together and align and centralize our goals for what we want to do to meet members where they are and get members what they need. There's a fragmented system in healthcare that has existed for endless times. We do not have the workforce to meet the needs of our members, and the health disparities are systematic and enduring. And so we believe that the waiver and the integration of the social care services into managed care will help transform the delivery system to bring in social services with primary behavioral health and other core tenets to whole person care. By way of background, New York has a long history of delivery system reform, as evidenced by our prior waivers. It starts back in 1997 with the partnership plan. There were a couple of other waivers before DSRIP, but then DSRIP really set the stage and laid the foundation and infrastructure that we're building upon in this recent NYHER amendment, the New York Health Equity Reform Amendment, which was approved by CMS in January of this year. At about $7.5 billion until 27. Most of it is federally funded, and that is really evident by how dynamic this waiver is. It's very big, it's very wide, and it will take an entire village to see this through. So we're going to go through each component of the waiver, but we believe that NYHER and the components of NYHER help address some of the health equity goals we have, as well as the population health goals. And it does try to establish incentives and goals that are aligned by all partners within the ecosystem. The newest piece of the waiver, the only new infrastructure in this waiver, is the social care networks. These are the core and main focus of the waiver and will play a pivotal role to bringing all of this together between physical, behavioral, and social services. They have a huge task before them, and it will take a lot of partnership and collaboration to meet the needs of each region and each community. We're really very close to unveiling the waiver. We're a little behind our schedule, but we still are set forth prior to January with a around the corner implementation date that I'll talk through. A lot of things are going to happen in the month of August, and we're super excited about it, telling you about that. If you take a step up, we're in population health, because the social care networks are going to focus on the integration of the services and bringing community-based organizations and other providers into the delivery system. But we're also focused on population health improvement and addressing some outcomes and health disparities that continue to persist. That will be done through a range of different initiatives, primarily focused around primary care transformation and stabilizing our financially distressed and essential Medicaid providers. And then there will be a coverage expansion to do continuous eligibility, 0 to 6, something that you'll hear about, I'm sure, from Emma later on. And I have to say, I am so impressed by the agenda for this conference. You guys are really in for a treat, and hearing Emma's perspective and Oregon's perspective is going to be very illuminating for what lies directly ahead for New York Medicaid. None of these things are possible without a strong workforce. There's not a place in the state that is not having workforce challenges. New York's waiver is unique in that we do have a very strong workforce component. There's about $700 million that will be allocated towards strengthening the workforce through 2 or 3 programs, depending on where you are in the career trajectory. And we're super excited about this because no one else has this opportunity, and we need to take advantage of it and really address some of the gaps that exist throughout the state. So let's start with the social care networks. These are the newest waiver entity that will be core to our success. And the way we've been trying to think about this is, how does it center around the member? Everything needs to center around a member's needs, and as well as the communities. And we think the social care network is going to integrate a new layer beyond physical health and clinical needs to integrate those social supports that are so core to well-being and community wellness. The social care networks will be led by a lead entity. Those lead entities are going to be formally announced in the month of August, and they are going to have a Herculean task to bring everybody together and ensure that we are working towards the same statewide population health goals. They'll be comprised of community-based organizations, primary care providers, behavioral health providers, other health-related social need providers, and they're primarily going to make sure that all members get screened so we understand what the social care needs are for our populations. Outside of that ecosystem is where we have some of the more traditional healthcare and social services players, the health plans, local government, child welfare, primary care. Those will all support or be supported through the work of the social care networks. The social care networks and the new services authorized under the waiver are comprehensive, and you'll hear about some of these from Oregon as well. We have tried to get as much flexibility as possible. So we have a comprehensive range of housing supports. These are services that are covered in various programs today. We're really trying to bring things that are happening on a micro level to scale, measure it, and ensure that it's being standardized and effective for continuous improvement, as Oxiris mentioned in her opening remarks. Beyond the housing supports, which are comprehensive, including 6 months rent, security deposit, other pre-tenancy supports, home remediation, and medical respite, there's a widespread range of nutritional services that will also be provided, which include counseling, medically tailored meals, food prescriptions, fresh produce, cooking supplies, and also health-related social needs transportation, which is very, very exciting. This is a huge social determinant of health. You don't just need transportation to get to medical care. You need transportation to take care of your family, to take care of yourself, to get training, to ensure that wellness is first and foremost. We had to fight very, very hard for transportation, and we were able to successfully get it. But it is, unlike some of these other services, it is capped. It has a capped expenditure authority, meaning it's going to be treated a little bit differently than some of the other services, like nutrition and housing supports. A lot of other navigation and core community-based services are centered around the case management, outreach referral, linkages to existing state and local programs, as well as connections to the clinical and primary care delivery systems as well. So as I mentioned, the SCNs really do have a Herculean task. We're going to announce the SCNs in August, and they are going to hit the ground running and need to form partnerships across the delivery system. First and foremost, they need to ensure that they are coordinating and organizing a network of community-based organizations and other providers that can deliver these services. We are assuming and somewhat using the data available to us to project demand for these services. We're not 100% sure that the supply exists and to what extent it exists in each region. That's part of why we're doing this, is that there is no existing infrastructure or data system to look to and identify. We're creating one. And so is Oregon, and they'll talk about their experiences there, but we're really testing something new and trying to bring two worlds that are very similar in their underlying goals, but very different in how they operationalize those things between social services and healthcare. So organizing and coordinating the network to ensure that the services can be delivered to members is first and foremost core to what the SCNs will do. They will pay CBOs and other providers for those services, and they will facilitate the data sharing that will be core to us to measure how effective these services are and how to course correct where needed or adjust in a nimble way. They will also establish a leadership team reflective of the community. We do want the SCNs to be reflective of their communities and regions, and we have set forth a set of guidelines to ensure that that happens. In designing the waiver, we tried to really minimize the impacts from the member perspective. The members should not be burdened to receive access to the services they're eligible for. We do have to screen them, and we know there's a lot of screening happening. So we'll talk about who is going to screen, how they're going to screen, and how it all connects. But we are going to have every Medicaid member screened. No matter what, that is a goal we have. It will happen. From those screenings, the SCNs will be coordinating referrals within the network to the appropriate provider, depending on the member's needs. And the health plans will be involved in helping assist to ensure that there's clinical criteria behind some of those member services so that we are tailoring the right social services to the right members, depending on their underlying conditions. So as we've gone through this, we've really been trying to balance being too prescriptive in telling the social care networks what they have to do, how they're going to do it, and what standards we're going to hold them to, while allowing there to be innovation, knowing that there are regional differences that are going to drive regional care models and partnerships. But we are going to have performance standards. We are going to hold the SCNs to performance standards that really are outlined in this slide. And those SCNs are going to be expected to have performance standards on their networks. We're going to start in a very inclusive way so that all providers should be included in the network. But ultimately, we're trying to get to a place where this is embedded in our managed care delivery system and is at risk in the capitated premium. So there will need to be stronger performance standards over time. And we've set it up so that we can be nimble, and we're developing an SCN program manual that will lay all this out and should be coming out in a couple of weeks. But the expectations are that everyone in the region is screened, and not only are they screened, they're screened in accessible formats depending on their social circumstances or life conditions. That is going to require multiple modalities of screening, whether it's telephone, video, virtual, in person. We're going to reach members where they are. We will expect timely assessments and referrals to the network. We're trying to align the time standards so that they are similar to what people may be familiar with in our managed care model contract. But this is new ground, and we are open to feedback when the manual comes out on how realistic some of these standards are. And we will be looking for feedback on that. I mentioned the inclusivity. We want partners in the network. No one will be at risk in the early periods of this waiver. We want to establish the integration and partnerships between two very different entities with two very different goals that are going to need to learn how to work with each other in an effective and coordinated way. And using the health equity as our overarching mission, things will have to be done culturally and linguistically competent ways with diverse stakeholders and meeting members where they are. So the member journey, it really always starts with the member, and we tried to simplify what the member journey will be like. And it all starts with the screening. So all members are going to be screened using a standardized accountable health communities tool for a core set of health-related social needs services: housing, food insecurity, transportation, education, interpersonal safety, employment. That screening is going to get sent through the social care network or to the New York eHealth Collaborative data lake that we're establishing. And members will then be identified using the screening and enrollee information from the managed care plans. So unlike DSRIP, we really wanted health plans to be integral to this design. So health plans have a lot of important information. They're very capable. They can help and will help SCNs know who in their region is eligible for these services based on existing clinical criteria and other claims measures to help target, triage, and ensure we are reaching the highest need members first, and that we are coordinating within the network so that all members get screened and we're not duplicating screening. So the health plan and the rosters is going to be very, very important. If the member is deemed to have a social risk factor in their screening that is supported by the managed care roster information, they will be eligible for the enhanced health-related social needs services, all those services we laid out on the prior slide. If they don't have a risk factor, if they're not in managed care, they're still going to receive case management from the network. They're just going to be connected to existing state, local, or other federal programs. We did have to tailor the enhanced services to the populations that need them. Some of that was driven by CMS, but in reality, we also want to ensure that we are measuring this for effectiveness to know what services are benefiting which populations and why. Some of the services are time limited or they have a duration. For example, the 6 months rent pre-post or cooking supplies, food prescriptions. People will be authorized for a duration in a calendar year, but it's not as though they're continuous forever. There are time limits for certain services, and if they do expire within the year, we will connect that member to the other existing services that exist within the region. Ultimately, we're tailoring this to target and reach the harder to serve populations that we'll share with you, not on this slide, but on the following slide. This slide is really getting back to reaching members where they are. Because if you think about it, we have 7 million plus Medicaid members. That's a lot of screenings. In order to do and complete those screenings, we're going to need to take a multidisciplinary and comprehensive approach where there is no single entity doing screening. Screenings are happening today. Health plans do screenings, health systems do screenings, community-based organizations do screenings. We're really just trying to standardize and take things to scale. But we are not going to prevent anyone from doing screenings today from doing screenings under the waiver. We are going to require that all members be screened. And so it's going to take extensive partnership and collaboration within the networks to be able to accomplish that goal. Everyone is going to have to roll up their sleeves, put their personal priorities aside, and come together to figure out how we're going to do this in the remaining 2.5 years that we have, because we really do think this is core to proof of concept and sustaining some of these services beyond 2027. So members can self-screen, providers within the SCN can screen, providers outside of the SCN can screen, and managed care organizations can also screen. All providers can refer to the network for screening. If someone shows up at the social services office, if somebody shows up at a community-based organization, they will get connected to the social care network, who will coordinate the screening and triage the services as appropriate. It's going to require innovation, partnership, and collaboration. And we believe that we have the technology infrastructure to really enable some of this. We're not going to get into the slides. I was contemplating it. It's very weedy, but we have put an extensive amount of time into planning and setting up this infrastructure to sustain beyond the waiver period. And the technology interoperability between the various systems is designed to do that. And the beauty of it is that it leverages the existing technology that have been created in prior waivers or prior delivery system reform initiatives, like the RIOs, like the Shiny, and the Medicaid Data Warehouse. So who is eligible for these screenings? We laid this out in the application. We've gone through this with CMS in the implementation, so we've had to get a little more granular. But these are the populations we are targeting for the higher level 2 health-related social needs services. First, they have to be managed care enrollees. They have to screen positive for a health-related social need, and they have to meet one of these criteria on the right-hand side of the screen. We've tried to be as inclusive as possible in focusing on those populations that we know need the higher level services, are harder to reach, and are typically the ones that are in and out of the delivery system due to their social circumstances. It includes our high utilizers, pregnant persons, including the 12 months postpartum, people with serious chronic conditions like our health home population, and the juvenile justice and criminal justice involved individuals who typically come out with multiple chronic conditions and in need of serious social services. It also includes the SMI, OPWDD populations, and those who have substance use disorder or need assistance with substance use. This is about, the last time we looked at it, 30%, 35% of our Medicaid population comprises of closer to 50, 60% of our Medicaid spending. But this is very much focused on the harder to reach populations that we were unable to reach in prior iterations of the waiver. And we believe that the way we've tailored the data infrastructure and the connections using clinical criteria, we will be able to measure very effectively as to what services are benefiting which populations and why. And ultimately, there's some other things we'll go through as to how we're going to do that. And the health plans are going to need to be involved to help tailor that so that we are actually triaging and using the limited time we have most effectively. So how are the dollars going to flow? I did share a little bit about this in last year's presentation, but since then, as I believe Melinda alluded to, there's been a lot of federal rules that have come out that have somewhat supported our approach, but also and enabled us to take this approach, but there will need to be a change at the end of the demonstration. So we have something in managed care called state-directed payments. Those are payments that the state can tell a health plan to pay a particular provider for a specified service and the specified payment rate. We can do those with special payment terms, which essentially means we're going to reconcile so that the health plan is not losing money and the provider is not losing money. We're really just paying for the services that were delivered, and we reconcile that at the end. That is the approach we're taking here. The final rule that CMS just released essentially is going away with that construct in 2027 and beyond. So we are excited to have this opportunity to leverage a non-risk structure within managed care, but ultimately the goal is to put this at risk in the premium. So we are very eager and excited for proof of concept. And I think Emma may share her experience in North Carolina, which is very encouraging as to our premise, which is that we will be able to reduce total cost of care and improve outcomes for our members. Initially, we're going to pay the infrastructure funds. These are the $500 million the SCNs have applied for. Those will go straight from the state to the SCNs to stand up the network, to do CBO training and capacity, to stand up the IT structure and ensure it's interoperable and data is flowing. That is a very, very large task. And we have to fight for these infrastructure dollars, but we want to make the most use of them. The state will also be providing a per member per month payment to health plans based on their level 2 rosters and based on the existing data that's available for the acuity of their members. The health plan will pay that PMPM to the social care network. The social care network will be reimbursing its network of providers on a fee-for-service basis. So CBOs are not taking risk. They will be reimbursed for the services that they deliver. The same can be said for the other providers that are doing screening, navigation, referral, or delivering the services themselves. We do eventually want to take this to another level, but we have 2.5, 3 years to be able to use a non-risk payment structure that I think should give everyone the comfort that no one is going to lose money in delivering these services. We are hoping that that encourages further collaboration. We are going to collect a lot of data we don't have to make sure that this premium is more reflective of actual lived experience. Right now, we're using a lot of different data sources to assume what people will use and where they will use it, but it's going to be refined over time. So where we start will not be where we finish. As Oxidis mentioned, there will be bumps. We will get things wrong. But the good news is that we are very, very committed, and we have a structure that can be nimble to be responsive to the various needs of a region or to be responsive to the standards that we're setting for the networks. So what next? We are right around the corner from announcing the social care networks and launching this initiative. We cannot wait. We know you cannot wait. There's a lot of anticipation. It is so close. I can't tell you how close it is. Ultimately, there is work that needs to be done once these announcements are made. As I was mentioning, the networks have a Herculean task. They don't have a ton of time. Everyone is going to need to mobilize and work together to accomplish what we're trying to do. But once we make the announcements in August, SCNs will be in contracting with managed care organizations and establishing their IT platforms and creating the networks. We are hoping to launch service delivery, starting with the screenings, of course, in October. So that is a very tight timeline and one that we are committed to. We believe it's possible, and it will be bumpy at first from the standpoint that each network is using its own possibly different HIT platform to integrate the social services. Some networks are already doing this work, so they may be able to get started sooner than places where it's a little unfamiliar or the network of community providers is not as robust. That's okay. Not everybody needs to start at the same time. There will be the opportunity for shared learnings. There will be the opportunity to get best practices, and the state will be providing as much technical assistance as possible so that everyone can hit the ground running as fast as possible. I cannot tell you who the awardees are, but what I can tell you is that there is not 13. We had said previously there would be between 9 and 13 because of New York City having its own distinct boroughs. There will be 9. There will be multiple SCNs in New York City. Taking it up a level, after we lay this social care infrastructure, we really are trying to take it up a level to focus on population health, because ultimately that is core to our mission and what we're trying to accomplish. We spend a lot of money in Medicaid each year. The outcomes aren't getting better in a material way or a commensurate way with the dollars we're putting in. We have made, thanks to Governor Hochul's leadership, a tremendous amount of investments in preventative care and in supportive housing. Those things are the down payment to success of this waiver, but the waiver is really going to expedite and bring together the prior investments with new federal dollars to expedite some of the transformation. But how are we going to measure this? we're bringing in all this new data, and it really starts with how we measure it, collect it. And that starts with what was previously called the HERO, the Health Equity Regional Organization, which we've innovatively rebranded to the SHERO, the statewide Health Equity Regional Organization. If you recall, we had started thinking when we had our concept paper and our initial application, there were going to be 9, 1 for each region. CMS was not interested in that, supported the concept, didn't want 9, agreed to a statewide health equity regional organization. And so for us, this is super exciting because we have so much going on with the social care integration. We're going to collect all this new data that doesn't exist or doesn't exist in a standardized way across the state. And we're going to have to integrate it and look at it holistically in the context of regional health disparities, statewide health disparities, health outcomes, and population health improvement. And that really is core to what the SHERO is going to do. It is bridging public health, social services, and healthcare, and facilitating partnerships to really address this in a regional way, bottoms up. We are not trying to tell each region or each community what the health equity priorities are. It's quite the opposite. And that's really what the SHERO is going to do. It's going to be core to convening all stakeholders and bringing a sense of overarching alignment across these various initiatives. Through the regional partnerships, they will convene what we're calling Quality and Equity Learning Collaboratives, or QELCs. Yes, government is very good with acronyms. The QELCs are, just a rebrand for bringing all stakeholders together, including those outside of the healthcare delivery system, to focus on regional and identification of regional priorities. That includes workforce gaps, value-based payment opportunities, and other things that are contributing to regional health disparities. They're going to establish regional health equity plans and engage in continuous population health improvement activities, something I'm very excited about, data-driven population health improvement activities. And they're going to share the best practices throughout the state so that we're learning from one another and not making the same mistakes, or innovating and working together in ways that we know has worked elsewhere. And I think some of the things Emma will talk about later will be core to how we think about this. In addition, they're laying the infrastructure for a data-driven practice and policy that can facilitate quality, equity coming together, all centered around better health outcomes for members. And also, it's laying a foundation that may become even bigger in terms of how we evaluate these programs and policies. So we're extremely excited about this. But it all starts with the data aggregation. We are going to have data flying all over the place, and someone has to bring it together, and the state's not always the best at that. We do have the pipes laid out and the systems operating so that an entity or a group of entities collectively will be able to aggregate and analyze this data, bring in other data from outside of the healthcare system to look at this in various ways, all centered around the outcomes and utilization and where connections exist, how that is resulting in better outcomes, where they don't exist, and how that's contributing to health disparities. So data aggregation is a core tenet to what the SHERO will be doing. They're also going to be evaluating in this continuous the data-driven practice of monitoring and improving programs by having a lens to what is happening in each region, and through the data being responsive to how we change programs or facilitate new partnerships. This is going to be core to how we address the underlying regional disparities, and it will all come together because the SHERO will have to do a statewide health equity plan. But more to come on that. We're hoping to announce that in August as well. Related, another core tenet to our population health strategy is advancing value-based payment. DSRIP laid the foundation on value-based payment. We are trying to take it a step further with a primary care-centered value-based payment strategy that really looks at 2 core programs in the waiver, but is connected and laying sort of the groundwork for alignment with primary care delivery system reform happening at the federal level, which we'll talk about. These are the new primary care models from the Center for Medicare and Medicaid Innovation. What we're doing in the waiver is not directly related to those, but it leads into those. And so it starts with the hospital global budgeting. There are 12 hospitals in the downstate area that are receiving incentive funding to prepare to enter into a global budget demonstration. They are reforming and analyzing a range of different things to prepare for that. And what a hospital global budget initiative really is it changes the incentives that we have today for a hospital to focus on population health and outcomes. That will be supported by enhancements in our primary care medical home incentive program, which will be statewide. We have the largest PCMH program in the country. DSRIP really established widespread adoption and certification of PCMH. We want to build upon that. And primary care is in need of dire investment, is in need of innovation and transformation. So we really are excited about bringing that to scale, and it aligns with 2027. 2027 is when some of these federal models take effect. And one of them you may have heard of is called the AHEAD model. It's the Advancing Health Equity Approaches and Development Model. It's a mouthful, another government acronym. But what it is it's a state voluntary total cost of care demonstration that includes hospital global budgets and aims to improve population health and reduce total cost of care. You may have heard of the Maryland model or the Pennsylvania global budget model. This is not that. It is taking from a range of different models that the federal government has done over the last 10 or 15 years and bringing it together under a health equity lens, which happens to align very closely with our 1115 waiver, which is why there's a lot of synergy here. What AHEAD is and what it will provide is it's going to offer, it's an all-payer demonstration, and it will be a 10-year cooperative care agreement. It includes some funding for states to do pre-implementation planning. It has a hospital global budget component, and then Medicare is making a very large investment in primary care. It's called Primary Care AHEAD. They are going to be providing enhanced primary care payments to practices that are aligned with the state primary care transformation, in our case, PCMH, meaning that Medicare will be making enhanced payments to PCMH practices in this demonstration. That will be on top of the PCMH payments we're enhancing. So we're trying to do some multi-payer alignment, knowing that Medicaid is not enough to move the needle. Everybody needs primary care. There is value to aligning with Medicare and commercial payers from a quality perspective to reduce the burden for primary care practices. And it is going to prioritize all the goals of a more equitable and integrated delivery system. So I'll go through the AHEAD application now. We are applying. The application is due in a couple of weeks. This model would not start until 2027. So the waiver will lead into this between the hospital global budget and the primary care delivery system model. Given the structure of the model and New York State structure, we are focusing downstate for AHEAD. 7.5 million New Yorkers in the region, 38 potential hospitals, sizable payments for the waiver hospitals that are receiving incentive funds. And this is what is unlocking the $2 billion we're investing in those institutions to transform themselves and to prepare to be in a demonstration in which revenue is not the goal, population health and outcomes are the goal. There'll be performance-based payments, and it will provide a lot of incentives that align with what we're doing in the waiver. And that's ultimately what we're trying to do, is line up the incentives so everyone is rowing towards the same direction, which is population health improvement and outcomes. Primary care, it is a primary care model. You've heard me say hospital global budgets a lot, but it is a primary care model. Medicare is making that investment. FQHCs, primary care practices, hospital affiliated practices will all be eligible for this enhanced Medicare funding. It is about $80 million annually for this region. If you layered in the Medicaid spending, it'd probably be over 100 million annually for this region. As I was saying, alignment is the goal here, alignment towards the same end outcomes and quality improvement that we're striving for. And there will be the opportunity for commercial payers to participate. We picked the downstate region based on the health equity needs, but also given the preponderance of Medicaid and Medicare spending in the region, we have the ability, or more of an ability, to encourage and incentivize those dollars to go towards population health. So what are the hospitals in the waiver doing from now until 27? They're going to use this incentive funding to both do an internal and external regional assessment for where are the gaps in their communities and in their patient populations? How can they advance health equity? And what do they need to do to advance health equity? What investments do they need to make to be able to meet those needs? They are going to be expected to do quality improvement, which will be a value-based payment advancement for some of them. It will start pay for reporting, but eventually by the end, we will have payments based on outcomes. And it's really going to strengthen that integration between primary behavioral health and the new health-related social needs services. So if we apply, when we apply, if we're awarded, we will be able to expand the AHEAD region downstate, and I'll go through this in the next slide. But there's a long way from the application to implementation. So there will be a lot more opportunities to engage with the community. There is a role for a community advisory board. So there is a lot more to this that will come in coming months. But what we're planning to do is apply for a majority of the downstate region, looking at the counties where the health disparities are most drastic, and also knowing where we have a hospital who's willing to participate in the model. You'll notice that Manhattan, Long Island is not included in this initial application. And the reason for that is once you apply, the region can only be expanded. It can't be constricted. So we want to make sure that we have provider education and participation in those geographies before we expand. We certainly hope we do. There has been interest beyond the waiver hospitals, but we're going to spend a year, if we're awarded, going through that process with stakeholders to see if there's real interest in those geographies. For the region that we've identified, these 5 counties, Bronx, Kings, Queens, Richmond, and Westchester, the hospitals in the waiver account for 40% of the spending in those regions from an inpatient and outpatient perspective. That's pretty sizable. We have had interest from other hospitals, and if they do decide to participate, we will be in the neighborhood of 70%. 70% of the inpatient and outpatient spend in the region could potentially be under the model, which is significant. That is without commercial payer involvement. So it just gives you a sense of the geographies that we are talking about. There are a lot of expectations, and this is not easy. And the hospitals will have a tremendous amount of work to do, both to fundamentally change the business model and be successful in a global budget arrangement. It is not about revenue. It's about efficiency and focus on quality, because people get paid more when the outcomes are better, which is what we really like about this demonstration. They will be required to share and collect more data, and they will be able to get technical assistance from the state and the federal government. There's a lot more coming on the AHEAD model, and I'll share a timeline later, but it is something that we'll be applying for on August 12th. At the same time, in the waiver, we're doing the primary care investments to advance value-based payment in primary care. It's been ignored for too long. We have seen the dearth of primary care providers, and you'll hear more from an esteemed panel on some of the challenges in primary care that we're really trying to address, and that their feedback has helped inform this strategy. It starts with the PCMH program. We have the largest PCMH program in the country. We know that people that receive primary care or PCMH practices tend to do better in the aggregate in terms of quality and outcomes. But the problem is that we're not measuring it at the practice level. We measure it at the plan level. So what we want to do is take the current PCMH program to be more of a prospective payment and move it towards value-based payment that is tied to outcomes. We have the waiver period to do that. We have been working with CMS on a state-directed payment. And ultimately, the goal here is to pay more for primary care, pay even more for better outcomes, and move towards value-based payment in primary care. Because PCMH is not your traditional value-based payment program today. So ultimately, that's the goal with what we're trying to do. We're including an enhancement for adults, enhancement for children. It will relate to these other federal models because we're streamlining the outcomes measurement. So there's no or less of a practice burden. And this is kind of how it comes together. We have our Medicaid PCMH investment from now till 27. Those PCMH practices in the downstate region will then be eligible for the AHEAD investment in primary care. Upstate, there are 130 primary care practices agreeing to participate in another primary care model. I call it more of a VBP 101 primary care model, and that's called Making Care Primary. That start date has been pushed out, but ultimately the tether between all these programs is that we're trying to advance value-based payment in primary care, and we're trying to pay more for primary care, knowing the impact it has on people and communities. So there will be a lot more to come on this. We've put a lot of time and effort into this and tried to align as much as possible with guidance from the federal government and feedback from stakeholders, but we will be engaging primary care practices later this year on some of the changes we're making in PCMH. In terms of the AHEAD model, there's a lot here. We're applying in 2 weeks. If we're awarded in the fall, we're going to spend calendar year 25 on like real pre-implementation planning, provider recruitment, provider engagement, making sure our systems are designed and set up. We're making investments in the all-payer database, which will be the core reporting mechanism to both manage total cost of care and also manage primary care investment and spending and track that investment and spending towards a goal that is much higher than it is today. I would be remiss if I didn't talk about the continuous eligibility for children ages 0 to 6. This rounds out the population health. Yes, and we are very, very, very excited about this, and credit to Oregon for pioneering this. We definitely copied them, and we are not shy about saying that. This is really the only coverage expansion in terms of a population that would be newly eligible, but is really core to our overall strategy to address health equity. We've seen, Melinda mentioned at the top, the public health emergency is actually not over, and at least for New York. And we have seen nationally some of the impacts it's having on children and their families. And we really think this will be critical to both in sustaining and providing opportunities for providers to really care for children and improve outcomes. The application is in the federal comment period. It just ended on the 26th. We are expecting to implement on January 1st of 25, but we have not yet entered into negotiations with CMS. They're obviously very supportive, and so we think we'll be able to meet this timeline, but a lot more to come on this. I have to give credit to the esteemed panel that will be speaking later today on primary care. They have been tremendous thought partners and been core to how we've gotten here and making this a core priority of the waiver. So I'll let them speak about it at the later panel. And to round out the waiver is really on the workforce. This is unique, and we have a wonderful opportunity that we've put a tremendous amount of time into with thought partnership from labor, from academia, and from providers to understand where the gaps are, what the needs are, how to bring health equity to the workforce conversation, and then filling very, very high demand gaps that everyone is struggling with and from a expertise and a professional level. Of the $700 million, about 650, so the bulk of it is going towards a career pathways training program. This is centered around ensuring two main types of people have access to career advancement opportunities in the health, behavioral health, and social services space. There's a career advancement pipeline that's for existing workers who have not had the opportunity due to social circumstances or other reasons to advance their careers. When you're deciding, if you're paid a per diem and you're deciding between whether to get trained to earn a higher wage or putting food on the table that night, those are really hard choices for people to make. That's not fair. And it really does prevent a lot of people from advancing in their career and having access to these opportunities. That's what the career pathways training is really about. We will be providing application and enrollment assistance and training programs, tuition assistance, case management and tutoring, apprenticeship, and mentorship opportunities for a series of titles. That will also apply to people who are unemployed or newly entering the system coming out of education. They will have access to enter the workforce. There is really only one requirement as part of receiving these trainings and getting these opportunities, which is you have to remain in New York State and work at a provider that serves Medicaid. So we want to make sure that the people that are getting trained are supporting the members that we're responsible for. And there is a 3-year service commitment. We've been working with a select group of high-performing WEOs that I'll talk about, but these are the titles we were able to get agreement on with the federal government for who would be eligible for career pathways training. There are a range of nursing titles at various levels with various training opportunities to move up those levels. There are professional and technical professionals that are mental health practitioners and primary care practitioners, including licensed mental health counselors, masters of social work, CASACs, and certified medical assistants. And then there's the frontline public health workers and that are really sort of core to community engagement, community navigation, like CHWs and patient care managers. We have very ambitious targets that will be refined depending on some of the needs of each region. But ultimately, we are hoping to train or place over 15,000, between 15,000 and 20,000 people in a very, very short time period. So the work is cut out for us. And the way we plan to do that is working with 3 high-performing workforce investment organizations. If you don't know what a WEO is, they were created under DSRIP in 2015, but they were focused on long-term care professionals and long-term care training. That is not the core tenet of this waiver. And so we had to assess, okay, of those WEOs that were created and that are still in operation, who can meet some of the demands and needs under this waiver? And so we went through a very large assessment to identify who was offering trainings beyond the long-term care titles, who had training partnerships with academia, who had the capability to stand this up quickly. And we landed on 3 regions, very distinct regions of various geographies. And we're very excited about building on the past investments that DSRIP started and sustaining that work moving forward. So what are the WEOs going to do? Oh man, they're going to do a lot. They're going to do a lot. And they're doing a lot right now. But they are going to be responsible for coordinating all of this for members, coordinating with the employer, the training provider, and other waiver participants to ensure that not only people get access to the training, they complete the training. It's not just getting access, but getting through the process is challenging. There are social circumstances, and they will be responsible for doing that. They will facilitate job placement. They will be tracked on higher wages. There will be a lot of standards imposed on them. The WEOs will also be formally announced in August, so stay tuned. Last is of the remaining $50 million that we have for workforce. I'll quickly summarize. We wanted to really target these dollars around reaching and identifying professionals that everybody is struggling with. They do not exist in the state, or they certainly don't exist in treating Medicaid patients throughout the state. It's a real problem. It's a real gap. It affects access. It is contributing to health disparities. It's not a tremendous amount of money, but we think it will make a tremendous difference to target it towards these high demand titles like psychiatry and child psychiatry, primary care physicians, dentists, and nurse practitioners and clinical nurse specialists. Every region needs these professionals. And so we're going to have a process to provide loan forgiveness. This won't start till next year, but make sure that those people will also have a service area commitment. So they'll be staying in the state and serving Medicaid patients at the end of the day. This timeline, August, goes through the waiver. I'm going to go a little quickly because this last slide, it really rounds out what the next 18 months looks like, and it's a lot. But we got approval in January, and by the end of December 25, we have a range of things we're going to do. You'll see on the slide, and this will be available, but we've broken it out by topic area, and we are working tirelessly, and we have miles to go before we sleep. The same will be said for all of you. We cannot do this without providers, community-based organizations, health plans, all ecosystem partners working together towards our ultimate goals to help people, to improve people's lives, and to improve community wellness. And so we're very, very excited. So I know the team is here. Please, we have a lot of team members here. I encourage you to ask them questions, get involved, reach out. We're very excited. We're going to make a big difference in people's lives, and we look forward to working with you on that. So that rounds it out.
Thank you for that presentation, Amir. Hello, everyone. My name is Alexis Simonetti, and I am a senior research analyst at UHF's Medicaid Institute. We are going to be opening the floor for a brief Q&A. So folks on Zoom can pop those questions in the chat. And if you're in person, we have microphones in the front of the audience. You can feel free to start lining up. We'll start with a Zoom question. So are there any longer-term plans to extend HRSN services to fee-for-service members? And what is being done to ensure these populations are not left behind?
Can you repeat the first part of the question?
Yes. Are there any longer-term plans to extend the HRSN service to fee-for-service members?
So I think very fair question. And first of all, fee-for-service members will still be screened and connected to existing services. So they will get some care navigation and navigation services. But I think this waiver is our proof of concept, right? If the services are both effective and having an impact on quality, there's a possibility to incorporate them in the state plan. We have a lot in our managed care waiver, but ultimately there's a lot of symmetry between state plans and 1115 authority. And so there is that possibility. It would likely be after 2027.
Hello, nice to see
Laura.
you. Thank you
Same.
for your presentation. I'm Laura Castle. I'm the coordinator of Medicaid Matters New York. We are a statewide coalition representing the interests of people who are served by Medicaid. I'm wondering if you could talk about your plans for oversight of this project. We're not supposed to be comparing this to DSRIP. This is not DSRIP 2.0. However, under DSRIP, there was an oversight plan that included an oversight panel that met publicly, that posted data. They were data dashboards. So could you talk a little bit about what your plans are for public accountability, transparency and accountability in this project, how stakeholders will be able to take part in that? Again, I know we're not comparing it to DSRIP.
okay.
However, there was a plan for that in the previous waiver design.
A great question, Laura, and good to see you as well. That has been something that's been a focus, not only of ours, but of CMS. And I think the ways that we're effectuating it through this waiver really center around the Shiro and the quality and equity learning collaboratives that the Shiro will do at a regional level, which will be solely driven by stakeholder input and feedback, and will be publicly, produced in our statewide health equity plan and create this continuous monitoring feedback loop. And on the health plan side, I think we have a number of contract changes that we're going to be putting into the model contract. There will also be standards for the social care networks, as I was saying. We're going to have performance standards that we expect will flow through the ecosystem, but there will not be this project approval and oversight panel because there's not necessarily distinct projects that are being implemented. But we will have an opportunity for stakeholders to provide feedback and course correct when and where needed.
Thank you. We'll do one more Zoom question. Oh, okay. Well, we can spread the love to that side. Go ahead.
Hi, Director Passeri. Thank you for coming today. I'm Jeff Brenner. I'm the CEO of the Jewish Board. We're a large social service provider. I'm also a family doc, so I should be really excited about everything you've said today, but I'm a little worried. I'm worried the SCNs are going to collaborate, or the Shiros are going to collaborate with the SCNs, are going to collaborate with the health homes, who are going to collaborate with Medicaid managed care, who are going to collaborate with the HIEs, who are going to collaborate with the PCMHs, and we're going to get sent lots and lots of new clients. And in our programs, last year we lost $15 million. We've done 3 rounds of layoffs. Right now, the state of New York owes us $9 million. We're probably going to have to wait another 2 months for that. We're drawing down on our line of credit. We've got huge vacancies in all of our programs. We've got in our housing clients injuring each other and injuring staff. We have just a litany of challenges. So a lot of this sounds like DSRIP. It also sounds like everything we said about Medicaid managed care 15 years ago. It's also everything we said about DSRIP. It's everything we said about a whole lot of reforms that have come and come and come. So I'm worried about the boring details of filling roles, getting paid, proper rate setting, all of those things.
Yeah, that's a lot, Jeff. Thanks for the question. I hope I don't owe you the money and somebody else does. But what I would say is I think we hear you in that there's a lot of unknowns and uncertainty. But the way you described it, this is what the social care lead entity is supposed to be doing. It's not SCN to health home to other provider to other provider. It's SCN to you. And part of the SCN's responsibility and standards that we held to is CBO capacity building. So to the extent you're providing high quality or critical services in the geographies that I know you are, it's on the SCN's best interest to ensure you're getting the dollars you need to do that. So I can't speak to, yes, there will be bumps. It's not easy to bring these two worlds together. It's very, very hard. It's very, very complicated. We think we have an infrastructure to enable organizations like yours to truly thrive in this waiver, to be completely honest with you. I don't think we see it as DSRIP. We see it as the best parts of DSRIP are incorporated in this waiver. And that's really on the WEO infrastructure, the PCMH infrastructure, the HIE infrastructure that we're leveraging to do this approach. So I think it's something that I would encourage you to be open-minded and optimistic before casting doubt. I know you will be. But let's see how this plays out. We're going to be putting out an SCN manual that I think will illustrate how different this is.
Good morning, Denise
Almost
Sothel,
friend,
an old friend, yes, a longtime Medicaid consumer advocate and a consumer representative to the state's Public Health and Health Planning Council. And Amir, my question today is about capacity. One of the things that we have seen over the last decade is because of budget cuts and hiring freezes that the Department of Health has lost an enormous amount of staffing and capacity. And this is a very, very ambitious plan, and it's very exciting. And I know there is new money coming into the department to hire new staff, but I want to know what you can tell me that will increase my confidence that you guys will be able to do this and do this as well as we need for you to do it, because this is, as I, this is very exciting, very ambitious. And I'm still looking at a Department of Health that is down by hundreds and hundreds of staffers.
Yeah, yeah, we are down hundreds and hundreds of staff.
And I would just say, I'm not picking on Amir. I have to flip. I ask the commissioner this question
Yeah.
every single meeting that we have. I say to him, Commissioner, where are we on staffing?
Yeah.
Um,
What I would say is we may have a small team, but we have a damn good team. And a lot of them are here today. They've been around, they work overtime, and they've been working nonstop. I have full confidence in our team on executing on this waiver. We are getting more resources. The state process takes time. But we've gotten this far with the team we have, and it's only going to get, we're only going to add to our capacity from here on out. But we really have good leaders in good positions that I have full confidence in our ability to execute on this waiver.
I would just say you all have full-time jobs already, and this just feels like, how much more can a person put on their desk? You know, it's pretty overwhelming. So I don't envy
Yes.
you, but I wish you the very, very best.
I appreciate, and it can be overwhelming. We do have a lot going on, but there's two things that we share in common, at least I see in my team, is we want to help people and we're deeply committed. And so I know that we are not going to sleep unless this is successful. And we are bringing on more resources. We are. The state staff takes a little bit longer, but we're in the position that we're in. I'm not worried about where we are now. We're going to get the resources we need. And you should have confidence in the team behind me. I stand on very, very tall, strong shoulders.
Thank you so much.
Thank you. We'll take one last question. And for folks on Zoom, we'll circle back after sending your questions to our colleagues at the state.
Thank you. I'm Yonit Lex. I'm a pediatrician at Maimonides. My question is related to health-related social needs screening. And we know that there's been a lot of energy brought towards that across many organizations who are now mandating it, like CMS, for different hospitals that are trying to figure out ways in which we can do this in a patient-centered way. However, we've seen a lot of hospitals in doing so are doing it in checking boxes and not necessarily doing this with patient-centered outcomes at the heart of it. And I just worry about the extent of which this waiver will have us screening, possibly over-screening patients, and doing so in a non-patient centered way and damaging more than providing good.
So thank you for the question. I think it's a very relevant concern. What I would say is we've really designed the incentives around the screening to not let that happen, right? So we've given people opportunities, not just clinical providers doing screenings, all providers doing screenings and reaching people where they are, which is patient-centered. We have to get to where the member is. Not every member is showing up in the doctor's office, right? In fact, most of the populations that we're talking about, the harder to serve, they're only showing up when there's an emergency. So there will be over-screening to a degree in the early phases, but that's part of the reason we want the health plans involved, and we built the data infrastructure we've had, is it will allow for the SCNs and their partners to triage and target screenings to those people who haven't been screened or who need to be screened based on their clinical criteria defining, you know, the statuses or the conditions that they have. So we think it'll be bumpy. We're not going to say we're going into this with any naivete. There's probably going to be some screening issues in the early periods, but we're going to be monitoring and have a system in which we'll be nimble to adjust and have visibility in all data inputs into the network and then through the QEs. It's something we're very mindful of. But I know, you know, most people are not comfortable or don't want to give screenings in a doctor's office. It is a lot of checking the box, but for some it's not. And hopefully it'll force integrations between those practices, those offices, and the network, which is really the goal.
Thank you. And with that, can we get one more round of applause for Director Amir Basiri?
I guess.
Thanks everyone for joining us today. My name is Giovanna Braganza. I'm a senior research analyst at the United Hospital Fund's Medicaid Institute. I have the pleasure of introducing our first panel of the day, which will cover coordinating care to improve perinatal and child health in Medicaid. The session will be moderated by Jeff Kazarowski, who is the New York State Chair and National Board Member of the American Academy of Pediatrics. Jeff is a pediatrician and serves as a professor and vice chair for community health and advocacy at the University of Rochester Golisano Children's Hospital. He also serves as senior health advisor of the Children's Agenda. Our esteemed panelists bring a wealth of knowledge and experience in providing perinatal and pediatric services across New York State. Janice Crystal Asensio is an obstetrician and gynecologist who serves as the acting chair of the Department of Obstetrics and Gynecology and as the medical director of the Ambulatory Women's Health Center at Jamaica Hospital Center. Maya Castillo is a pediatrician and serves as the assistant vice president and pediatric medical director at Health First. Madeline Dorval-Moeller is a licensed clinical social worker and serves as the executive director of the Northern Manhattan Perinatal Partnership. Katie Punica-Worms is a pediatrician who serves as the assistant vice president of pediatrics at the New York City Health and Hospitals. Full bios for all of our panelists are available on the website, and I'll turn it over to Jeff to start this discussion. Thank you.
Hi, everyone. I'm Jeff Kazarowski. I know we were all settling in just a minute ago while Giovanna was introducing the panel. So I'm going to say thank you to Giovanna, but I'm going to make a few comments, and then I'm going to have each of our panelists say a little bit more about themselves, and we will have 5 questions that they help us to answer, and then we'll take audience questions. But I'd like to talk a little bit first about what's happening for maternal child health, for women and children and pregnant people's health in New York State. I want to say thank you. Thank you to all of you. Thank you to the Department of Health and Commissioner Basiri for 0 to 6 continuous coverage. And I want to say thank you for requiring that women and pregnant people and children are a requirement in the 1115 waiver. That hasn't happened before in my mind. And I know there are a lot of unanswered questions. I know we're all worried. I know there's tension, but this is really an opportunity to change the way we do things for our kids and families. I want to say a little bit more about that before our panelists talk about the settings in which they do their incredible work. First of all, you all know that women and pregnant people and children are the poorest and most diverse segment of our population in New York State. Over 50% of our children and pregnant people are on Medicaid. Medicaid is the #1 insurer for our children and our women. Health equity, the whole focus of the waiver, health equity begins with women and children. And it's not going so well. Yeah, health equity begins with women and children, and it's not going so well, folks, right? You all know that since the pandemic, our infant mortality rate in New York State has actually increased. And there are tremendous disparities in our infant mortality rate, and it's personal, folks. It's personal. Black infants are 3 times as likely to die as white infants. In the Finger Lakes area where I am from, infant mortality is about 1.5 times greater than in New York City. I see it. I feel it. It's horrible. And then maternal mortality. On the front page of the New York Times, how many times this year? Special commissions set up. Black women 5 times more likely to die than white women. And the commission that investigated this found that 76% of it was preventable. Okay? So thank you all for making sure that we focus on women and babies. And I'll say just one last time, health equity begins with women and children. And I am so glad to be here with these 4 panelists. I have had the chance to work with some of them personally, and I've had the chance to meet them all as we've prepared for this, and you are in for a special treat, especially if I stop talking. I am going to have as a start, I'm going to have Maya start, and I'm asking each of our panelists to just do 3 things to reintroduce themselves, because I think it was hard to hear when Giovanna was introducing them, to tell us just a little bit about where you work, because we'll get a lot more into that, and to say why. Because I think one thing that's really incredible about these folks is the passion and commitment they have. So if you could tell us, Maya, those 3 things, it would be great. And then Katie, I'm going to go to you next.
Thank you, Jeff. My name is Dr. Maya Castillo. I am a pediatrician by training. In fact, I did all my training in Washington Heights, worked for many years in that community, in that neighborhood. And I've been the AVP Pediatric Medical Director for the last 4.5 years. And Health First is not where I expected to be. I never actually expected to work at a health plan, but something about it really spoke to me. It is a not-for-profit plan that takes care of nearly 2 million New Yorkers. 1 in 4 New York City Medicaid recipients is on Health First. And we have almost half of the dual eligible Medicaid, Medicare members in the New York City area as well. So it is a population that is near and dear to my heart, and really focuses on trying to deliver the best access and best care to the people who need it most in this area. What was your second question, Jeff? What personally brought us to this?
Yeah, I think the last part is, why do you do what you do?
Why do I do what I do? I think I saw as a pediatrician working with families in New York City, I saw the tremendous disparities that the patients I had in my private practice who had insurances could get easy access to many things. They didn't have to worry about transportation, food, other things, whereas my Medicaid and patients really struggled with many things, and I really couldn't help them, and I wanted to be a part of changing that. And I really saw transforming the way we pay for healthcare as the way forward to creating health equity. And working with Health First has shown me that that really is the way forward. I really think working on payment and keeping health equity as a focus, keeping these populations as a focus, is a way to improve the health of the entire population. So that's why I do what I do.
Thank you so much. Katie, can you tell us?
Yeah, absolutely. Pleasure to be here. Katie Punica-Worms. I'm a pediatrician. I actually practice as a pediatric hospitalist at Bellevue Hospital here in New York City, but most of my time is actually spent as Assistant Vice President of Pediatrics at New York City Health and Hospitals. We're the largest public hospital system in the country, a really And we serve over 1 million patients every year, about 30,000 prenatal patients, almost 200,000 children and adolescents. And our families and children are predominantly Medicaid and CHIP enrolled, so about 85%. And this really offers up some really unique opportunities and challenges. You know, we're in VBP arrangements with some of our main managed care organizations. And so we can really, you know, partner with our health plans, with the city, with the state, and all the incredible innovative work, you know, that we're doing to really think about alternative payment models and what we can do around care integration and Medicaid. When I popped up at New York City Health and Hospitals, you know, really being able to do something at scale was so exciting. I was so inspired not only by the amazing work that our 11 acute care facilities and, you know, 20, 30 federally qualified health centers were doing, but also inspired by what we were, our mission and vision within central office and the incredible work the city and state was doing to continue to push these limits. So really a pleasure to be here.
Thank you, Katie. Janice, do you mind going next?
Of course not. Good morning. Good morning still. So my name is Janice Crystal Asensio, and I'm here as an OBGYN representing Jamaica Hospital, pretty much the Medicis system. That hospital, can't hear. All right, so are you able to hear better?
Yes.
Fantastic. So my name is Janice Crystal Asensio. I am the acting chair of the OBGYN department at Jamaica Hospital right here in Queens. And pretty much here representing the Medicis system. The Jamaica Hospital is about a 402-bed non-for-profit hospital. And what we have been able to do there is the equity work that we're speaking about has been work that has been done there forever. And now that attention has been turned toward it, we have an opportunity to really showcase that work. Now, in terms of maternal health, the reason why I love what I do is there is a deep, diverse population that we are able to serve in that community. It's probably like the most diverse urban population on the planet in the Guinness World Book. And so we get that opportunity to serve those patients day in and day out. You know, I look at women's health as healthy women, healthy world. We are the ones who birth the next generation. And so many times that health has been sidelined. And so that is why I endeavor to do what I do, because if you see healthy women, you see healthy generations to come, and that is your best bang for your buck.
I love it. That was great. And
I
Madeline.
guess I'm next. Good morning, everyone. Can you all hear me? My name is Madeline Doval-Muller. I'm the Executive Director of the Northern Manhattan Perinatal Partnership. I'm really deeply honored to be here this morning. First of all, I'm the only non-physician among my panelists, so I represent the community. And then, so I'm really happy because by me being here, so you understand the medical establishment, understand the role of CBOs, the role CBOs play to address health equity. Without CBOs, the work cannot be done. And yes. And then I feel our work is not valued enough, but I'm happy that they recognize our work. Our organization, as I said, Northern Manhattan Perinatal Partnership, and we are Harlem-based. We serve Washington Heights and Inwoods, and now the Bronx. And our mission is to save babies and to empower women to take control of their reproductive right, health, and then well-being. And other than PPE, what we want to do, we ensure women have health insurance, they enrolled, they attend the primary care visit, and then we work with them before pregnancy, during pregnancy, and after pregnancy until the children are 5 years old. We also have a Head Start in Washington Heights where children who live the program can enroll in our Head Start program. And why I do what I do and why I do that, I've joined this organization 7 years ago. And first of all, you can see I have a French accent. Almost 40 years ago, I came here and then I spoke English, but I didn't speak English. And so I was being from Haiti, you know Haiti, and then I was privileged enough to have an Ivy League education. And then so everyone, I'm passionate along with my team at NNPP to ensure that women don't die from preventable death. And as Jeff said, we know 75% of maternal death will happen to be Black women, Latino women, are preventable because they are associated with unmet social need. When we are social, I mean, those of you know, you call it like social determinant of health, but it is unmet health-related need. Whether a woman is about to lose their home, if you are losing your home, and then the last thing you're gonna think is about your health. At an NPP, we try to connect people with housing. We try, a lot of people don't have food and security, that's what we see in there. And then a lot of people don't have diapers. And then we do health education, we provide doula care, we provide postpartum doula care to ensure that we provide a really full holistic model of care. And then myself, we work with a team of CHWs, all of them speak either French because we work with a large population of French African immigrants. We work with Dominicans immigrant, and then Mexican. We have also a large population of South American, Afro-Latina, and I never heard of that language before until I came to NNPP, Garifuna. They are Afro-Latina, and then who are many of them living in shelters. And then we're trying to help everyone who comes out of. What I want to say, at anyone who comes at NNPP, we treat them with respect, dignity, and compassion.
So this next question, Katie, I'm going to start with you. I'm going to try and tell everyone where I'm going to start so that I give everyone fair warning. This next question is going to follow up a little bit on what Madeline just suggested about team care, and also what Amir was talking about with regard to making sure that we have preventive approaches. So this question is big picture about prevention and team care and programs and services that we sort of integrate together, Katie. So the question is, prevention and early intervention programs that integrate mental health, pediatric care, and perinatal care aim to improve the long-term health of the family unit. There are many models of integrated care across New York. How do you use care integration in your preventive programs and services? And what role does care integration play in prevention and treatment within your programs? So Katie, I'm going to let you speak, and then if there's one or two other panelists who want to add to that, I know you might want to, we'll follow up with one or two other panelists. Thanks, Katie.
Yeah, perfect question, wonderful question. Integration and prevention, I think, are on all of our minds. And really, I want to take this opportunity to thank United Hospital Fund, because back in 2016, they put out an incredible white paper by Suzanne Brundage that really laid this out nicely about early childhood dyadic care and preventative care and what that model could look like in New York State. Then a special thank you to New York State, and I always get this name wrong, but there was a white paper and a report from the New York State First 1,000 Days Preventive Primary Pediatric Care Clinical Advisory Group. They did not come up with a fun acronym for that, which they really should have. And that has some leaders that are sitting in this room and you know, across the state who worked on that together and really created what's called the Advanced Pediatric Primary Care Model. So this whole thing around integration, early childhood care, you know, is not new in New York State, and we've been really well supported through that time to think about this. So it's really focused on 2-generational health, you know, knowing that we really get the biggest return on investment from the earliest investments we do in, you know, children and perinatal health. Really thinking about how children don't take themselves to the doctor. You know, they're accompanied by their caregiver, you know, their mother, their legal guardian, you know, their family, and there's so many touch points that young child has in the first 3 years of their life. I think AAP recommends at least 12. And so this is really a really important area where we can innovate, you know, within this space. So 2-generation, you know, dyadic care, universal screening. So how can we bring screening across social determinants of health, development, autism screening, as well as social emotional screening, postpartum depression screening into pediatrics, and then help connect families where we need to, on all of that. So fast forward a year, 2020, in the fall, and through amazing public-private partnership, as well as our own health system investment, we modeled an advanced pediatric primary care model at New York City Health and Hospitals at 3 of our pilot sites. It's called 321 Impact. And this combined a lot of what New York State supported in their advanced primary care model. We have Healthy Steps, which are these early childhood specialists who really focus on prevention, development, dyadic care, incorporated, made sure we had reach out and read programs, make sure we had early childhood community health workers navigating to early intervention services, CPSE, social determinants of health, enhanced our integrated behavioral health for those postpartum patients, those postpartum mothers, those families when needs were identified, and then also did incorporated some evidence-based parent coaching programs. We use Play, Read, VIP. With all of that, we were able to then, through temporary additional funding, expand really system-wide and thinking about pediatric practice transformation. So leveraging the incredible grants from OMH in New York State, building out Healthy Steps at more practices, and then through some amazing city funds, being able to build out our early childhood community health workers system-wide, through internal investments, building out tablet implementation work to really focus on universal screening across a lot of those, things, and a couple of others. But I said temporary funding. And, this is where I think, Maya and I will talk about this more later about how you sustain these models. But, the rubber is really hitting the road for us in the next couple of years. A lot of these temporary grants, these venture funds that we have, are running out. And we've been so thankful for the incredible work that New York State has been doing to try to think about this. 0 to 6 continuous coverage, preventative mental health billing. So billing without a mental health diagnosis, and being able to do that. We're now going to be piloting community health worker billing across peds and adult primary care in August, and taking advantage of that incredible opportunity. But despite all of this, we still can't fully sustain these models. And there needs to be that discussion and decision we all have about when do we just start to think about additional alternative payment models. And we're working on one together with Health First, where you really think about how you fund those non-fundable pieces and really, invest in early childhood with that long-term cross-sector return on investment. So I'll pause there and turn it over to you.
Yeah, I think I'll just speak a little bit to the sustainability piece at this point. This has really been, I think, a learning experience for Health First as well, because whereas, we were able to do this because of our unique relationship and our value-based model, it still wasn't easy because we found that there were a lot of barriers. For example, as Katie said, when you're treating a child, especially 0 to 6, you're really treating the parent a lot of times. And there's not a lot in billing models that allows you to apply treatment for a parent to saying this is for the child, right? And so many times the parent is on a different health plan than the child. And even we found that when the child and the parent were on the same health plan, there's not a family ID. So it was very difficult for us to link their data and be able to look at outcomes and say, what we're putting into this program is showing outcomes across both mother and baby. And so, there were a lot of lessons learned in this that thanks to, the partnership with the state and their listening to us has allowed us to move some of this forward and make it a little bit more sustainable. But yeah, a lot of the pieces that really go into this sort of population health model are not widgets that you can sort of bill one off. They are things that need to be thought about on a larger scale and as more of an investment. And so, we're working with H&H to try and figure out how can we make this as sustainable as possible through enhancing billing, through how do we create coverage for these non-billable pieces, or create a new value model that's looking more at outcomes rather than these specific widgets and paying for that.
Wow, that was great. And these panelists, these guys are so in tune that Maya was actually answering the next question. But I want to say it's very exciting to start to think about value-based payment in pediatrics. Many of you know that in the waiver, and Amir talked a little bit about this today, there was a commitment to look toward value-based payments specifically in pediatrics because of the challenges that Maya and Katie have talked about. I want to let folks know that there is a national compendium, in addition to looking to Maya and Katie, who are a great example, and one of the few examples that I know about, there's a national compendium of value-based payment examples coming out from the American Academy of Pediatrics this fall that does include these folks, but also other examples of value-based payment that I think will be great to take a look at as we try and forge our way forward toward alternative payment models in New York State. But I want to give Janice and Madeline a chance to comment if they want to make any comments about what we just talked about, or we can move on to a next question.
Sorry. I do want to say something because based on the value-based payment, I felt like the CBOs are left out. As I said that we have some good integrated model that works because we have, for example, a partnership with NYP Hospital. And then I think that it is a replicable model. I think we have some of the team here and Dr. Sepin. And then that we have a contract with them, 3 contracts where we hire CHWs. The CHWs have access to the client's records when they make home visit. And then any problems they have, they put it in the client records, and then the provider, the doctor, can see what the problem is. But this program, and then also we have doula, postpartum care doula with them, which this model seems to be working great, and then it's saving lives. But there's so much you can do because it's only served patients who are also only giving birth at NYP Hospital. But where I feel like to sustain the work, I think that hospital in the room should partner more with CBOs, and then the health insurance such as Health First can also do value-based payment with CBOs for those like, what's the term? Non-billable work that we are doing to advance the work. For example, we do work with making sure that for somebody may have trouble getting the child to the hospital. Let's say a child with chronic health disease, but the CHW knows because they know this person doesn't have childcare. So it's not like this child, the parent is neglectful. It's because all these problems they're facing daily in their lives. So, and then the CHW is making sure that they try to help them, and then yet we don't get paid for that. So CBOs need more value-based payment to sustain the work. And then, most CBOs are not federally qualified health centers. They are CBOs like us. And then we can't bill. But by if Health First and other MCOs partner with us, do value-based payment, we can save more lives. I said, investing in women's health and children is investing in the future.
Yeah, exactly right. So there's some complicated things going on here, and I'm going to try and sort them out a little bit and hope to be right. One is, as Katie mentioned, community health workers can now receive payment through New York State for care of women in pregnancy and postpartum, and also children 0 to 21. But they have to be affiliated, to Madeline's point, with a practice, with a medical setting. And then I also just wanted to say to Maya, I just want to say thank you over and over again to you, because even when we achieve those kind of things, we get all excited about that, right? Have those community health workers for reasons that Madeline said, although CBOs can't be reimbursed for them. But Maya has been thinking about how to put the whole package together for a long time in some way that's proactive, where it doesn't rely on every single time submitting a billing claim. And that's where it gets really, really exciting. And we know, to Madeline's point, that taking care of our most vulnerable, right, poorest and most diverse segment of our population is a team sport. It's a team sport. There is room for all of us to participate, and we all, as Katie talked about, need to lend our talents, and we need to work together as teams. So thank you. That was just amazing. This one is going to be a question. Let's see. Janice, I'm going to have you start this one, okay? All right. So this is about the perinatal period overall. And this is a broad question, relying really on your expertise. So how do we begin to rethink perinatal care, specifically care around women? What are some important considerations for that to assure that women, and particularly women of color, receive the additional services that are needed to improve those health outcomes that we talked about? What are some collaborations that you might recommend? What are some things that Jamaica Hospital is doing that you think could be foundational? Or what are some things that you wish you could do at Jamaica Hospital if you could wave your magic wand?
Thank you for that question. So with women's health, how we approach the care, pregnancy sometimes can be a very isolating time, and it depends on the surrounding comorbidities. So if a patient is pregnant and they have a chronic disease, it adds many, many layers to the care and support that that patient might need. And so looking at patients critically and making sure that we recognize that pregnancy is almost the time that we have for women that they're a captive audience. At that time, we can then actually assess them for their health-related social needs, and then we can go ahead and place them into care and support that would help to round out their care. Some big things such as oral health and its correlation to long-term health considerations, heart disease and such, that patients probably thinking, my mouth is so far from my uterus, how can it relate? They don't know. So there is a component of health literacy that really undercuts how we treat these women. Putting them into social services care, checking for diabetes. Patients come into pregnancy not recognizing that their pre-existing issues such as obesity, cardiovascular disease, diabetes actually put them at much greater risk. What I can tell you about what I've seen over the plus 20 years that I've been doing this is that the acuity of our patients has tremendously increased. They are so much sicker right now. And so when you look at the mortality and morbidity rates that we're seeing, it is not surprising. There's some things absolutely preventable, but it's preventable because if they understand that their pre-existing conditions put them at risk, then they can almost try to address those things before becoming pregnant. So what are the issues? First, patients don't recognize that pregnancy is a very dangerous time, right? And so they enter it very, very much caution to the wind. They don't recognize that if I'm obese, I'm just going to become more obese. If I have heart disease, it gets worse. Everything gets worse with pregnancy. So I think health literacy is number one to really lay a foundation. The other thing is providing support for these women. What we have recognized is that we are so grateful for the doula services. We are so grateful for the community health workers being able to be reimbursed. But what are the issues? For us at Jamaica Hospital, we have programs such as Centering Pregnancy, which are group pregnancy models, and that's really helped to build camaraderie. Patients feel more supported. They have a family, as it were. What we've found is that there's some unreliability with outside doula services in terms of trying to tie patients in. It has become so inconsistent. And so what we believe would work better is having a homegrown doula program, one which is sort of in hospital so they can come everything from ante to postpartum, still receiving that consistent care. The other thing that we're looking to do is chronic disease management centering. So centering has been at Jamaica since 2014 and has been successful. And we were able to pivot during the pandemic and to make a virtual option present, which we found was an incredible model. Right now, what we're doing is looking at diabetes as a really tough disease to manage in general, but in pregnancy, so untenable. Patients are just like, I was told I could eat anything I want. And right now you're telling me I can't what? They just like, I'm hungry, I'm gonna eat. So how do you provide the support that patients need to really round out their experience during pregnancy? Well, what we're doing is we're providing navigators and really looking to Maya's team at Health First, because Jamaica has a value-based arrangement. They mostly, of course, in the primary care space, but we can borrow from that in the maternal space. And they have actually allowed now for us to have patient navigators, which has really changed the game. So we can have greater help with increasing compliance with their visits, understanding better what is going on with diabetes. And as I said before, the group pregnancy model gives them that camaraderie. I can't eat, you can't eat, what are you doing? So around nutrition, cultural differences, because we just tell patients, you can't eat this, you can't eat that. But if we culturally look at what is it in this, what I eat, that you can eat, pick those things out and help those patients build supports, it really is a great model. I'll add one last thing. One of the things that I more recently recognized was it makes sense as a provider that if you have chronic disease, that it does impact you downstream after pregnancy. But what I did not realize was the impact of preterm birth, stillbirth, heart disease, and that patients at points and diabetes, 4 to 8 times risk of stroke, disease from heart-related conditions that these patients have no idea. They don't realize that pregnancy is the great stress test. And if you have any of these conditions, it puts you at risk downstream of having real issues. So the expansion where you have now 12 more months not only gives us help in looking at mental health issues and being able to really intervene, but it also gives us help in looking at these patients who now have a greater risk for heart disease, and many of them don't understand that. Thank you.
That was amazing. Do any of our other panelists want to add to that? I'm not sure how you would add to that. Okay, Madeline, how about this one for you? This is about the waiver and some of the social supports in the waiver, and how you think they might be impactful and where you see there might be barriers to their implementation. So here's the question. Pregnant individuals and up to 12 months postpartum, children ages 0 to 6, and children ages 0 to 18 with chronic conditions will be eligible for health-related social needs support through the NYHER waiver. Individuals will receive temporary assistance with rent, utilities, nutrition support, and transportation. How do you think these proposed health-related social needs services will address the needs of pregnant people and children? What challenges do you foresee in supporting Medicaid members with their unmet health-related social needs through the waiver? And so, Madeline, we're going to start with you, and then, as always, other panelists can add afterwards.
There's a lot of questions. I don't know if I can remember them all.
Just think the waiver
I'll
and
try to. I'll try-
housing, nutrition,
I'll
transportation.
try to do my best. First of all, I'm really happy for this waiver, and I really want to thank everyone from the bottom of my heart who worked to make this waiver happen, because I think the waiver will save life. It's a life-changing plan. And for example, women will have, postpartum women will have rental assistance till 6 months. And then postpartum women will have nutritious care until for 12 months until 2 months postpartum. And then so many our clients and then many of CBO's women of color and people that we serve, and over 90%, they all Medicaid eligible. They have diabetes, they have high blood pressure. You heard what Johnny said, and then all these are contributing factors. So this waiver, I think, helps a lot because women will have continuous care until for up to a year. And then whether it was CHWs to a hospital. So we will continue to do health education, which Janice mentioned, because people need to know what the problems, especially people who are obese with diabetes, we're gonna continue to do all this health education for them. And then, so many of our clients, and then many of people, Janice's constituent, we have diaper insecurities, we have lack of housing, all these problems, and then we'll help. But the challenges I see in implementing the waiver, I'm afraid we won't have, they will have, I would say, the words not coming to me, unexpected expectation of the CBOs. They think the CBOs will be able to do miracles because we won't be able to do all this. Because one thing, we have a lot of people live in a shelter. We pay them for 6 months of rent, which is great because it helps. But what's gonna happen after 6 months? You know? And then my solution, I think, here in New York City, we don't have enough of housing. The providers, the hospital gonna send them to CBOs, said, okay, go and go to the CBOs. The client's gonna be mad at us because we cannot find them housing. And then we live, especially in New York City, our clients in Washington Heights, in Harlem, in the Bronx, they double up. They don't have housing. This is the richest country in the world. And then we can build housing. We're not building housing. For me, if people don't have housing, they're about to go to a shelter, and then it causes all kind of problems, stress and everything. You have people, okay? The plan's going to provide meals for pregnant women with chronic condition, but many of them live in a shelter, right? And then, so they won't, what's gonna happen? They need a home where they can cook because you have a lot of people, because even though you give them meals for a year, but if you really want to provide culturally related food, if they have a home, they can cook. We can do the health education for them. And then, but they can purchase their food and then cook their own meals. And then all these are barriers. For example, for rent utilities, they're going to help with utilities because the city right now have a shortage of employees. And then I can see long waiting lists for people to get assistance with utilities. Those are the barriers I see. But I am very grateful we're making the first step, but we need to work more to ensure health equity, because if we want a just, equitable society, we need to address housing need for every citizen, every New Yorker.
Don't you hate the lack of passion? Do any of our other panelists want to add to that question? If not, we have one question left, but it's a big one.
I just wanted to, in thinking about the social care networks and 0 to 6, and I saw, in August, all will be revealed, as Amir said, but very excited for August. But, I saw some asterisks, across some of the pediatric populations and some of the others, 0 to 6 at risk. To me, all 0 to 6 is all at risk when you're on Medicaid.
Right.
Poverty is a risk. And I know some of this is probably outside, New York State is talking with CMS and, there's negotiations there that are ongoing. But if we start to think about that population, if there are then clinical criteria that also need to be met within there, and we're relying on claims-based data to funnel from the health system to the MCO to the SCN, even in our best data platforms, I know me as a provider, I sometimes don't put the right code in. And I also know that I don't put the right code in every year, and so I think there's just going to be, I'm worried, just around some of those missed opportunities where you may navigate a family and that they're eligible, but by the time they pop up to the SCN, even a very well-meaning SCN that's trying to find out how to make them eligible, if they don't see what makes them eligible and don't know how to ask, we may be missing a lot of families who could benefit. And the other thing I'll say is the screen that they're using, you know, that is supported does not ask about childcare. And that makes me nervous because we know childcare is a huge issue across New York State. And we know that part of doing this screening is really to understand the needs of the state. And if we're not collecting that data on the childcare needs, even if the SCNs are able to then navigate people to childcare, it's going to rely on each individual SCN to furthermore screen for that, which is going to be hard. They already have a lot on their plate. There's a lot of responsibility that was put on the SCNs in those slides. So that's what I wanted to add.
Those are really terrific points, Katie. Thank you.
So I just want to add actually onto what Madeline was saying, because I think one of the other things that people don't recognize are epigenetic factors and the trauma and different things that then actually impact on a mother who is pregnant, and this can actually pass on to the unborn child. Not only does it have impact on that individual, but it's twofold, right? So it has impact on that baby. And if we think about, not to go into too many details here, but if you're pregnant and you're pregnant with a daughter, as it were, think about if you're a woman, your grandmother carried you. And so the impact of that, you know, at 20 weeks, we have all the eggs we'll ever have. And so if your grandmother was pregnant with your mother, you were there and your eggs were there as well at 5 months pregnant. So the impact is deep. And I think we need to recognize that the monies that we have allocated toward chronic disease management, where we are funneling money to take care of people who are baked, we're adults, we're sick, it's just not the best investment of your funds. The better investment is going to be in your women who are the ones birthing your next generation. If you're an insurance agency looking at actuarial sciences and where your best bang for your buck will be, you need to take care of the women in your society. It is the only way forward.
And I just want to clarify one or two things. With regard to what Katie was saying, there is a health-related social needs survey that is proposed being used that does not include information about childcare. And it's problematic because in the pilots that New York State did for the New York State first 1,000 days, they did 4 pilots in 4 different regions, one in New York City, one in Albany, one in Chemung County, and one in Rochester. Childcare was, by the parents involved, by the caregivers involved, one of the top 2 things that was identified that parents wanted help accessing. And yet, on the screen that's being proposed to be used statewide with regards to the waiver, the current status is it's not going to be asked about. The other piece that Katie was pointing out and that Janice so nicely followed through on is that in the waiver, for those of you who've been following this closely may know this already, but all women from pregnancy to 12 months postpartum are included in the waiver, everyone. And we thought all children from 0 to 6 were going to be included. We thought. And they're not. And that's very problematic because if you look at poverty, the younger you are, the poorer you are. The younger you are, the poorer you are. And also, exactly what Janice just said about that egg and that embryo extends to the early years of life, right? You've all heard this data, right, from the Center of the Developing Child. 1 million new neurons per second in the first 3 years of life, per second, are forming. And now CMS has come back and said to the state, we really can't have all children 0 to 6. You have to identify some risk factor. How about brain formation, maybe? How about poverty, maybe, as a risk factor, right? How about that exactly what Janice said is true, that what happens in those early years lay the foundation for health for an entire lifetime. So it's really a hard struggle. And Katie and Maya Janice and Madeline, many others of you in the room really tried to help the state with regard to that negotiation. We don't know where it currently stands. All right, our last question sort of lends right into that. We're gonna, for the last question, we have 5 minutes left. We're gonna do teams. We're gonna do Katie and Maya together, and then we're gonna do Madeline and Janice together. Then I think Giovanna's gonna come up and we're gonna take questions from the audience and from Zoom. So this question is about what we've just been talking about, the expansion of coverage. And so for, we're going to talk about the expansion of coverage in New York. We expanded postpartum coverage for pregnant people. It went from being just 2 months out to 12 months. We were just talking about that. And then we expanded continuous coverage for children from 0 to 6. And the question is, how can we leverage that? How can we leverage that? Can you think of some creative ways that we can leverage that, health or otherwise, so that beyond the surface value of that, which we know is amazing, right? How might we otherwise leverage it to really improve health outcomes or collaboration, to improve things for our women and kids? Maya and Katie, do you want to start?
And I will briefly add on to whatever amazing things that she does.
So, I really think about this now at this point from the payer perspective. And so I think what we know is that the churn we saw from people dropping out of coverage, and this is something that we've seen in this post-COVID world, most people who lose coverage lose it because of administrative reasons. And the burden on the person that's affecting, as well as everyone surrounding them, the doctor trying to figure out how to see them when they no longer have care, the insurance trying to get them back on. If we eliminate that with this continuous coverage and make access easy, that alone is going to improve care and free up a lot of finances that were going towards this administrative churn and this administrative burden. So I really do thank New York State for being forward thinking about that. My second part in answer to that is that I think knowing that we are going to have these populations insured and covered and paid for longer periods of time does then allow us to do more within payment models as well and really focus on value and quality. So just to kind of respond to something Dr. Asensio said, she said, this is, if you're an actuary, this is the biggest bang for your buck. Well, actually, if you're in a commercial insurer, it's not, because people tend to change insurers very frequently. But I'm lucky enough that I work for a not-for-profit where we're not trying to make profit and we keep people for longer periods of time. And we're all lucky enough that we're in a state that is seeing that return on investment is not necessarily short-term, right? Yes, New York State has a budget. Yes, they have to think about this from year to year, but investing in women and children's health over a long period of time will pay off in spades later on. And not only in healthcare with savings related to less diabetes, less mental health admissions, but also in improved educational outcomes, more stable families, right? So it's not just going to pay off to New York State within health. It's going to pay off to New York State across everything. And I think that's where really we can take this money and really invest it in not looking at short-term ROI, but rather quality outcomes and longer-term outcomes. And that's really what we need to use this more continuous coverage to do at this point.
Wow.
He actually said it perfectly. I'm just
All
going to
right, all right. Thank you, Maya. Janice and Madeline?
So thinking about what we can do, not to beat a dead, horse, but When you have this expansion, many times our patients would have, preeclampsia or other hypertensive diseases of pregnancy. They'd be discharged from the hospital, be seen at that 6-week visit if they had a vaginal delivery, and at 8 weeks is that the extension for a C-section. Now we have that much more time, not only for education, but to follow up on those blood pressures and to see that if once their blood pressures, for example, have not gone back to normal, we can then get them into additional care if needed. The other things that we can do, and one of the things that we're building right now, is a cardiovascular disease model, a group model, where patients who have delivered can now be handed off to our cardiology colleagues. Not only are we endeavoring to educate other providers about the risks of cardiac disease, which is the #1 killer of women, but we can also now put those patients into care where they can have that year to get an echo or whatever other additional services need to be done to ensure their health and wellness. And so these are the ways in which I think that expansion will help, and we can use sort of to leverage the health and wellness for our patient. The other killer for our patients is mental disease. And so now we are able to have, with that expansion, and one of the things that we have done is we have now embedded psych services within our clinic. So we have about 5 that we have 10 ambulatory sites, but 5 in which we see women. And what we're doing is we're embedding that psych care under the label of wellness care for those patients. So they're able now to come in one-stop shop, not only get your postpartum check, but you're also able to endeavor to get those psychiatric services without the labels that would be ordinarily placed there. And so that's I think ways in which we can leverage it.
Well, you all answered my question. So, but anyway, what I would say as a CBO, I said it's more partnership with CBOs and hospital, because hospital don't make home visit. So we know when you can find your client, we know where they are. We can make sure they attend postpartum visit. We know exactly our CHWs with what the clients are going through. So if you have more partnership with the CBOs, I think we can leverage it. And also, I am not a doctor in the room, and then in terms of like the mental health, and I know many of our clients said that, well, we know when we try to link them with mental health, and then many healthcare, they don't take the Medicaid. They don't take Medicaid. And then so, as I said, I'm not a doctor, but I think Medicaid should pay more for the payment, so they can take our client insurance, because many of our clients said that Medicaid doesn't want to serve them. And then why? Because, as I said, providers said that Medicaid don't reimburse them enough.
So as Giovanna makes her way up to the microphone to moderate for us, we want to make sure on behalf of the panelists that we thank United Hospital Fund. Your team is just incredible. And Chad, Shearer, and Oxiris Barbeau, you guys are role models for us all, and you have been so helpful in advancing perinatal and child health. Thank you, thank you, thank you.
Thank you so much to this inspiring panel. Definitely learned so much from you all. We'll now move on to our audience Q&A. I'll invite in-person participants to line up by the 2 mics we have at the front, and I'll take a Zoom question just to start us off. So this is a broader thought question. What do you see as the biggest policy impediment to making progress on perinatal and child health?
What was the question? If I can, that's a big question. I mean, I think I kind of said this at the beginning, but and it's not just health and hospitals, but I think across our state, there are health systems working so hard to take advantage of every opportunity we can. We are working on optimizing billing, from the New York State, updates coming, whether it's for preventative mental health, whether it's for, screenings, whether it's for CHW billing, expanded social work billing, taking advantage of the postpartum, expansion of coverage and 0 to 6 expanded coverage. Despite all of this, the New York State recommended model for the advanced pediatric primary care model still can't be sustained without thinking of additional funding. And so how do we really change the way we think about pediatrics and invest really taking that big Medicaid pie and saying, look, if we're going to help with and much needed help with high risk, high cost, high utilizer, chronic disease management conditions, how do we move also some of that funds upstream for upstream prevention? And we're not going to see the immediate 1-year ROI. And that's really hard, I know, for health plans, health systems, and state Medicaid programs to really grasp. But if we think about investing in evidence-based models that show those long-term investments and maybe set up some process measures to show fidelity to those evidence-based models that health systems are doing, we could make the case for enhanced payments for these types of early childhood models supported by the state, supported by the nation. Thank you.
I would say that the biggest policy that's been a barrier is actually what's happened recently with cutting of the quality pool funding by the state, because we use that quality pool funding to be able to pay for quality rather than widgets. And, that funding was what paid for the navigators for Dr. Asensio and allowed us to really be able to put money towards moving things forward in a way towards outcomes and quality rather than your standard just payment. And so I think that really is, for me, what stands out as a policy.
I think it's not any one policy, but we repeatedly underfund anything for women and children. We should have a women and children's budget, and we should track it every year and see the investments go up. Primary care, 5% of Medicaid pays for primary care. Early intervention had its first rate increase this year, and it was a 5% increase first time in 20 years, and it's markedly insufficient. Pediatrics is in an existential crisis. By that, I mean, we're not sure pediatrics is going to continue to exist. Where will children go for immunizations? There are already kids who are not getting vaccinated, have no access to primary care. This is the state of things. We repeatedly say we value women and children, and our policies absolutely demonstrate the exact opposite. This is why this is exciting. This is why it's exciting to be here. But we have a long way to go. And I think if there's got to be some way to measure our progress over time in a meaningful way. It's multiple policies that fail our families over and over and over again. If we want to have a governor who's the mom's governor, maybe we want to have a budget that's about moms and babies.
I echo that. It's just in terms of the thoughts that are put toward women and children, it's just not the priority. And as I said before, this just needs to shift. Paying for quality for Jamaica's involvement in the value-based model has really helped us to improve the health and wellness of our population. And especially when you are in a catchment area that has so many needs, it really helps. For our institution to be able to be graded by Health Grades as among 100 America's 100 best hospitals in a space where we're a safety net hospital shows you the commitment to quality. And having these numbers be cut back, it really impacts the bottom line and could actually cut away the things like the Navigator program, which has been really helpful in advancing maternal health and well-being.
Do I have the last word? Again, I'm not a physician, but I read a lot about the health. America, among industrialized countries, have paid the highest cost for healthcare, but yet we are not healthy. So that means we are not prioritize our care. We like to do patchwork. So I echo everything my panelists said. So we do need to invest in women and children because they are our future.
And we'll take one last question. This kind of builds on what you all talked about. What are some barriers to obtaining adequate investment in these effective team-based care models that you mentioned? And what opportunities may exist through Medicaid to help fund some of these things?
Yeah, we kind of talked about this, but just to reiterate, our data systems, our quality, measures are not really set up to think about prevention, long-term dyadic savings, cross-sector savings. It's really interesting to think about now we're going to have continuous coverage for children 0 to 6. What if we also had continuous family coverage, 0 to 6? And we could really think about, we're able to link in our health systems, EMR, mothers and children, if, the patient is delivered at an H&H facility to the first 5 years of that child's life. And it's really helped us to think about integration in a really meaningful level across that family unit. There's ability to do that at the MCO level and the health system level, especially or the Medicaid level, if we stop the churn and people are able to really hold that child accountable for the first 6 years of their life. So there's definitely some potential, and that I'm looking forward to. But otherwise, yeah, it's very hard the way the current data systems are set up.
I think in terms of barriers, I think one of the biggest things for me is that even though we say that we're moving towards value-based care in New York, and we say we have value-based models, the guidance that the state is still putting out around Medicaid is still very much in terms of billing for widgets. And I understand it's difficult. I mean, this is the way the system has been set up, and we get the results that we have because of the way the system is set up. It's hard to think outside of that. But if we could, hopefully with these ahead models and these more value-based global payment models, maybe we can start to move away from the paying for widgets and start to think about what are outcomes, what are quality that we can use to pay by, rather than having it be based on, did I get the right risk score coding, and did I bill for this person 6 times what I'm allowed to bill for them, right?
Yeah.
So I think that would be my biggest point.
Building on that really quickly, yes, payment reform is essential, and more money dedicated to women and children is essential. But to follow up on some of the questions that happened this morning for Amir, people, whether they're at community organizations or whether they're doctors or whether they're school teachers, when change happens, people need help with the transformation. And, if we're going to move to value-based payment, practices are going to need help with that. And CBOs are going to need help with that. And I think if we're going to do this waiver, boy, are we going to try hard to do this waiver for our kids, right? And for our women. But we're going to need help. And I think the expectation sometimes is, we put the money out there and people will respond. And that just doesn't always turn out to be true. It's an and. So we need an infrastructure that has to be built over time to support women and children too, if that makes sense.
So really piggybacking on what you said, I think the barriers, and to tie into some of what Madeline has said, is how do you tie together all these pieces that were proposed in terms of the hospital care? We found out, as Madeline said, that you can give a patient the prescription, you can talk to them about the concerns you have. But what we found, we just obtained a grant for community health workers, and when a community health worker can go into the home, much of what Madeline has been saying, and tell you actually what is happening in that space, it makes a world of difference. And so I think the barriers would be, how do we make sure that we tie in properly the services that we provide for our patients with those from the community, and really integrate that. And I know that hearing what Katie has said, that seems to be really good that they've had a system at H&H to do that. And I think that will be the next barrier. If we can overcome that, it will help a lot to integrate that.
I mean, some of the barriers, for example, that 1115 waivers include doula payment. So I'm really happy they have also payment for doulas, because a few years ago, many of us probably didn't even know what a doula does. And then so far we have a lot of MCOs reaching out to us. They said, okay, we want to do a contract with you to provide doula care. I said, okay. And doulas are independent contractors. And they said that I'm willing to pay you the rate for the Medicare paying, but what Medicaid paying is it's $1,500. And then, at least in New York City, $1,500 per care, it's nothing. And then, so if you want me to bill for the doulas, do the billing for the doulas, and then I have to have someone to do the billing. I have to hire someone, right? And then that's what, when you do the system, do the implementation, it doesn't work, because, and then if we want doulas to help, and the CBOs also have to match a doula with a patient. But who's going to be doing this? CBOs have to hire someone. But if you just give Medicaid only paying $1,500, and already $1,500, as I said, I'm happy because you put in doulas in the map. But it is not enough money. So you have to give me, you have the MCO has to give the CBOs money to hire someone to do the billing, and then a coordinator to match the doulas. So, and then, so all this work, it's a good positive step, but I don't think they involve enough CBOs in the thinking. Of course, they always leave us behind, and then they expect you to fix the problem. So I'm just thinking, like, think about that when you reach any CBOs, think about all these administrative costs. Those are the barriers that we're gonna have to implement the 1115 waiver.
Thank you again to our panelists.
Good afternoon, everyone. Welcome back from lunch. I would like to introduce one of our generous sponsors, Unite Us, for some after-lunch remarks. We would like to thank Unite Us for making it possible for folks to attend our conference virtually for free, so thank you to Unite Us. And joining us today is Alex Lipton, the Chief Legal Officer of Unite Us, and you can find Alex's speaker bio on our website.
Good afternoon and welcome back from lunch. My name is Alex Lipton. I'm the Chief Legal Officer of Unite Us, a technology company based here in New York that powers cross-sector collaboration between government agencies, healthcare providers and plans, and community-based organizations that are all working together to power and connect people to the health and social care services they need to lead healthy lives. I'll just give everyone a minute to jump in. All right. A big thank you to Dr. Barbeau and the United Hospital Fund team for a fantastic event already. Unitas is proud to support and sponsor this event and to sponsor virtual attendance at no cost for all of the attendees listening online. As we've heard just from this morning's panels, the topics and the learnings are too important to limit to the confines of this room. So really excited to serve as a sponsor again this year. At Unite Us, we kick off each of our all-team meetings with a story about an individual or a family that we or our partners have impacted. And so as we transition to the afternoon panels, I wanted to actually share a story about how Medicaid impacted my own life. When I was 3 years old and my brother was 10 years old, my brother suffered a traumatic brain injury that devastated our family. My parents are not doctors. It was the first time that they were navigating the full complexities of the healthcare, insurance, and government program systems all at once. That would have been fairly impossible to navigate for them, but for New York Medicaid programs. And it's thanks to New York Medicaid programs that my brother was able to receive high quality, round-the-care support in the comfort of his home, surrounded by his family for the remainder of his life. And so I'm very excited to be here. I'm very honored to be here because it's that had a transformative impact. New York Medicaid had a transformative impact on my brother's outcomes. He lived for decades after that incident. It had a transformative impact on my parents. And of course, it had a transformative impact on me. And it inspires the work that I do with Unite Us, where we work on the ground to execute and implement on all of the important initiatives that you've heard about here today. So as we continue learning from each other here today, I would invite all of you to continue to center ourselves in the impact on the individuals that we serve. That's how we at Unite Us do it, and I hope that we all continue to do that today. I also want to take a moment to thank all of this morning's panelists. Melinda Abrams, thank you for starting our morning with the important reminder to center the people we serve. To Director Basiri, thank you for the very energizing discussion on the New York 1115 waiver. Unite Us is proud to serve as the technology and implementation partner for 1115 waivers across the country, including in North Carolina, where our payments platform has facilitated nearly $90 million in reimbursements to community-based organizations for the critical social care services that they provide. Thank you also to all of the speakers on the phenomenal perinatal and children's health panel this morning. So important to, again, center women and children and to address and to talk about how Medicaid can have a meaningful impact on addressing the maternal health crisis in this country. It's a critical pillar for Unite Us as well. In fact, we heard reference to the first 1,000 days programs in New York. In Florida, one of our partners, a first one that's also running a first 1,000 days program, was able to demonstrate a statistically significant 79% reduction in postpartum related admissions for individuals who were served through our technology. And so we're very proud of the work that we've helped drive, and just so honored to hear the perspective of the doctors and CBOs on how we can advance that work through Medicaid initiatives as well. This afternoon, we have an exciting set of additional panelists. So we have our friends at CityBlock, Dr. Matthews and Chad Shearer from the United Hospital Fund. We're excited to hear their perspective, as well as you heard earlier today, the Oregon Medicaid Director, Sandeau, who's going to be speaking about her perspective about the opportunities and challenges that we face in implementing these complex yet incredibly promising waivers. So thank you again to everyone for taking the time. As we all know, we are all very busy doing the hard work that we're discussing today. But thank you to everyone for taking a moment today to step back from that daily work, to learn from each other about how we can advance our shared mission. And thank you again to Dr. Barbeau and the United Hospital Fund team and all of the rest of our fantastic sponsors and panelists. Unite Us is looking forward to working with all of you on these important initiatives in New York, and for those from outside of the state, elsewhere as well, to advance sustainable, transformative care for the people that we serve. Thank you so much.
Thank you so much, Alex, and thank you to Unite Us for their continuing support. Before I sit down, just want to really appreciate you sharing a personal story that helps us do what we've all been doing today, trying to do today, putting the Medicaid member at the center. And I think in this conversation we're about to have, you're going to hear one really innovative model that's doing that every day on the ground. So I'm going to sit down. I suppose I should have introduced myself first. For those of you that don't know me, I'm Chad Shearer. I'm Senior Vice President for Policy and Program at United Hospital Fund. And it seems like every year, for some reason, I get the best assignments at this conference. Today is absolutely no different. So much of what was discussed this morning is really all about meeting people where they are, recognizing them as whole persons with a bevy of existing supports, challenges, and needs, and having all of the necessary pieces in place to help individuals live their healthiest and best lives. When we put the Medicaid member at the center, it's so easy to see the inherent benefits of team-based, multidisciplinary, integrated physical, behavioral, and social care. But no one ever pretended that that is easy to do. The waiver really opens new realms of possibility in New York. But as you also heard in the morning panel, there's plenty of innovation already happening, especially when it comes to more integrated, multi-generational care for children and families. And I'm just extremely excited today to be in conversation with someone who is delivering on the promise of team-based whole person care every day for Medicaid and Medicare members in New York and across the country. Dr. Cameron Matthews is Chief Health Information Officer at CityBlock Health, an innovative value-based healthcare provider integrating medical, behavioral, and social services. Many of you may have heard something about CityBlock, but I promise you, hearing about it from Dr. Matthews is an absolute treat. And there's no better time for all of us in New York to learn from what they are doing. So Dr. Matthews, thank you for being here. I think I misquoted your title when I said it. So why don't, before we start really digging in on your model, tell us a little bit about yourself and how you came to City Block and your role there.
Thank you, Chad. Hi, everyone. Oh, turning the mic on, it's like taking the mute off of Zoom. None of us know this, right? Thank you. Thank you, Chad. Thank you, Dr. Barbeau. I am a family physician first and foremost. I pride myself on really having focused my career on helping not just the people that have traditionally walked into my exam room or the like, but also the communities in which they are a part of. I have really spanned the gamut, and I apologize. I know this well. I am in a New Yorker crowd. I've never lived here before, and I apologize for that. That's a shortcoming on my part. I recognize that. But I did train and work the first part of my career on the South and West sides of Chicago. Not the same, but similar. But recognized in every way through my training, through the multiple FQHCs I worked with. I was at Cook County Jail for a while, treating the inmates of Cook County. That there's a need for us to think about healthcare outside of our traditional models. That our traditional models, while they may be, especially those of us who've gone through clinical training, it may be touted as the best. It may be taught to us in a format that allows us to emphasize our own personal achievements that in every way can be counterproductive to how we're actually then providing that care in the community. So I've been fortunate enough to happen upon City Block. Toyin was an idol of mine, and then she called, and I still am in shock and awe that I've been here now about 2.5 years. Prior to City Block, just in case you guys didn't necessarily read the bio, I served in the Veterans Health Administration during the last administration and the first year of this administration in our central office in Washington, D.C., where I'm located. I first worked in and led the managed care department for the VA, and then became chief medical officer of the whole health system during the second year of the pandemic.
Fantastic. Well, thank you for being here and for sharing a little bit of your background, because I think it will say a lot about kind of what you're doing now. Talk to us a little bit about kind of how City Block is putting the member at the center of its, integrated care model, and, how you think about kind of compassion and trust as key elements to the success of your model.
Thank you for bringing that up. I think first and foremost, it's something I haven't seen in other practice environments, but that we value in every way in City Block is that we are earning the trust that in many times has been rightfully not present with the people that we're serving. They have been in every way traumatized, whether it's in their actual community, through personal relationships, or traumatized by the healthcare system as a whole. And I can speak to that personally as well, although I never was a part of the Medicaid program. I can definitely speak to the extreme difficulty that my family actually in the past couple of years has faced in navigating the health system. And we actually understand the healthcare system. We're actually a part of the healthcare system, and it was extremely difficult. So part of what City Block really is moving, I think the goalposts around is how do we actually think about what integrated care looks like? And so as much as the conversation this morning was dynamic, there's so much amazing work going on in New York. What if we stepped back and reconsidered the actual infrastructure in which we even consider the medical model, that we're separating still health-related social needs from medicine? What if we brought that all together? That we're separating, even in medicine, for those of us who are physicians in the room, the way we train in our siloed academic specialties that have absolutely no relation to what our patients are actually going through. And we're referring back and forth between specialties as opposed to actually bringing them together in an integrated manner and treating not just the patient, but the family as well. So in City Block, that's really our goal, to provide that one-stop shop opportunity. Again, not exactly a new notion. I mean, so much of what City Block does, we're not saying that we've, cornered the market as far as innovation. Federally qualified health centers have been doing this for decades, right? What innovation we're bringing to the forefront is also our business model. We are a fully capitated, value-based model. In the Medicaid and dual space, which in and of itself is sadly enough still innovative. Like, I actually want to challenge more companies to start doing this because of the very need that I believe value-based care will actually be able to meet, and that our fee-for-service system isn't necessarily addressing. We are multimodal in the sense that there's a lot of companies out there. If you're looking at those startups, those digital health, they use the term virtual first. I actually think that is completely counterintuitive for the communities that we're serving, that we're trying to earn trust, but then force them on a screen first. That's absolutely unacceptable in our minds. So multimodal, meaning we will be in the home, we will meet them on a park bench, we will have them come to our hub. Sometimes they like that formality. Sometimes you don't have privacy in a home enough to do a virtual visit, and you do need to come into a hub. Maybe there's an actual physical exam that needs to occur, and we need to do that in an exam room. But then a great deal of our care is virtual as well, too. And as far as social drivers of health, in my mind, not asking patients to actually leave their workplace when they might not have PTO, or leave their home when they might not have child support. I actually think virtual care is a response to social drivers of health. So multimodal in the sense that, exactly as you said, Chad, at the opening, we are here to meet the member where they are and not force them to our ivory tower.
Fantastic. Well, I definitely want to come back to the payment and the technology, but before that, talk a little bit about what it means in practice to put in place these multidisciplinary teams that are required to provide this integrated care. And then what does that look like from the patient perspective?
Yeah. So our integrated care teams are, everything we do is primary care as a chassis. I'm 100% believe in the importance of primary care and really tying that even to public health, something a lot of other countries do, but we don't necessarily. So for us, the primary care team just has a much broader definition. So we include not just behavioral health. A lot of places describe behavioral health integration, and a lot of times that just means co-location. It also tends to not, unfortunately, be able to address the higher acuity behavioral health. We actually have full scope psychiatry on every single one of our care teams, along with counseling, along with care management. We have, at the crux of all that we do and how we communicate with our members, our community health partners. We refuse to call them workers because they are partnering with our members instead. They are the main point of contact. They are the one that they reach out to. I don't want them to even, I mean, maybe they need to know my name, but I don't want them to think about Dr. Matthews. I want them to think about who their partner is that's probably going to be knocking on the door, bringing them potentially some food or supplies, attending their specialty visits, meeting them in the emergency room if they actually have a concern. And that's what our CHPs do time and time again. We have RN care managers. We have clinical pharmacists, a program that we've built out in the VA where I formerly was for decades, but that the rest of the healthcare system really hasn't turned towards, as far as having a clinical pharmacist actually manage chronic disease and acting at the top of the license, managing a panel, actually directing some outcomes. That's part of our team as well. I know I'm missing others. Oh, the bigger picture is also expanding beyond what is traditionally primary care. And so we have a community paramedicine program, which I know you're familiar with here in New York. We call it our mobile integrated care team. And it's actually a team of emergency docs that are part of our practice, that are licensed across all of our markets, and that are providing virtual services as well as hybrid services, meaning the community paramedics that are in each of our markets are actually in the home, and the emergency doc is on the screen. So we can take labs, we can drop lines, we can do EKGs, we can do everything. Some limitations here in New York, however, I do need to throw that out. We do have some limitations on our mobile team capabilities here. But this is really about integrating within a single practice, and even within our care teams, the different disciplines that our members need. I think one of the biggest benefits, I meet with our providers just one-on-one throughout the year just to say hello. We're scattered across 7 states. We have about 100,000 members at this point. So we're pretty expansive. I don't get to every clinic regularly, but I get to meet one-on-one. And some of the best feedback I regularly hear from our staff is that they absolutely are feeling that we have been able to address at least the larger concerns of healthcare workforce, burnout, and the like because of the way our model is structured, because we're not forced into this fee-for-service environment where we're driving volume, right? Because they actually have the team members at the same table discussing the patients with them. That's the one thing, first and foremost, our psychiatrists always point out. Our psychiatrists always said, this is the way psychiatry should be practiced. We should be integrating it completely as a part of primary care. So we talk about how integration needs to occur, but then when it comes down to it, we still organize ourselves around a medical model in the larger healthcare system. And that's what we're challenging with our interdisciplinary teams.
Well, and I think you just led me to what is it about the payment model and capitated payment that really allows for that? And when you think about, your plan partners, what are you seeing in terms of outcomes from, this model that is really making this an attractive opportunity for your plan partners?
Yeah. Capitated payments or other fees-based models. Some of our contracts aren't fully capitated. We're on a pathway there. Allow you to right-size the care team, allow you to think proactively, particularly about the population that you have some accountability for. And I think that's actually one of our largest shortcomings in the fee-for-service model. We only feel that responsibility. I hate to say this, I've been guilty of this. This is how we're trained, but you tend to feel responsibility only when that patient is within the walls of the hospital or the clinics or whomever. Of course, we're trained to go bigger. We're trained to think of it, but it's unfortunately a burden on the healthcare system at times when we're trying to think about patients holistically. So for us, being able to have that accountability, know that we're responsible for all care for that member, regardless of whether it's a service we've provided in our clinics, or whether it's something they receive at H&H or wherever, we are financially responsible. So therefore, we build our teams to address that. I can send our CHPs into the hospital, into the home, because the member's entire world is our exam room, not just our brick and mortar. So the payment structure allows you to think ahead, allows you to plan on a population level, and allows you to build some efficiencies because you're not so focused on individual encounters, which of course upstream of that is about individual documentation and who's the billing provider and how do we need to make sure maybe the incident to gets adjusted and all of that. That's irrelevant in our space. And so we're really building out, capitalizing on our multimodal approach. So I have virtual teams that will cross into states because we're all cross-licensed. I think I have 12 now. I'm just going to keep going. And we are purposefully, therefore, designing our services to meet the needs that our members are expressing, and to do so outside of the bounds of the traditional payment system. So the capitated payments allow us to plan for that as opposed to react to it.
Well, the people that know me in the room know that I would love to just dig in on the very specifics of how this payment works, but I'm not going to. I do want to call back to something that you mentioned about kind of some of the barriers to your mobile team here in New York. And as you think about your model, what you're able to do in New York State, how that's different from some of the things that you're able to do in other states, and are there regulatory barriers, just broadly that we need to be thinking about in terms of, being able to promote models like this?
Yeah. And I apologize. I realized you asked the question about outcomes. I did not shirk that
Oh,
question. I will get back to that.
I missed it. Your answer was so good. I didn't come back to it.
I'll come back to it. We've got some great outcomes. But no, so this has been, many of you know, City Block was founded in Brooklyn. We really do consider ourselves part of this community, and we've expanded beyond that. Our most recent state, we just opened in Florida in May. What I described as far as our mobile integrated care team has been a phenomenal addition, again, to our primary care space, because we're really expanding. I mean, talk about burnout of our workforce. Our primary care docs don't need to take call because I've got a 24/7 mobile integrated care team over here, right? We're thinking about holistically how providing services and not putting it on the backs of the primary care teams, which is critical as they themselves during the day are dealing with just the complexities of a patient population that you all know that can really cause some vicarious emotion, correct? So the difficulty, unfortunately, in New York is that we have limitations on how we can actually deploy our community paramedicine program. Based on regulation here, paramedics who are trained to go in the home, who are trained to deal with social needs, who are trained to not just respond to acute issues, but also larger emotional response that's happening in a space that can be sometimes quite difficult to respond to. So we think they're the most appropriate to be going into the home, and of course, need to be interacting with our emergency medicine team. Unfortunately, in New York, paramedics can only work in acute care sort of scenarios. They can't be the team in our homes, in our members' homes, who are providing what we call facilitated primary care, because sometimes our paramedics are going in and it's our primary care doc on the screen. So that's one restriction we found. We've, of course, followed the regulation, complied in every sort of way, and have built our team structure differently here in New York. But the skill set that comes with the paramedics is so paramount to the success of that program that it is a limitation, unfortunately, here.
So going back to kind of some of the technology you were talking about earlier and, you know, how that plays out in your multimodal model, you know, how else do you leverage technology beyond the virtual visit? And thinking about this patient population, how do you help clients kind of navigate, you know, access and use of that technology when it can actually be a huge benefit for them to do a telehealth visit, as we've, you know, finally learned during the pandemic?
So we, in every way, our community health partners do a great deal of this, the rest of the care team as well. We in every way attempt to address any broadband connectivity issues at all. But we also offer just straight telephonic visits as well. Sometimes they can just take a phone call. Sometimes that's all they actually have the capability for at a given moment. Maybe they're at work, maybe they don't have connectivity and we haven't been able to help them. So from a patient-facing standpoint, we have been able to address concerns, and it's a very individualized issue, but definitely a social driver that we always want to question and address. The majority of our tech enablement, though, as a practice, is really about assisting the care teams and the workforce. So we have a proprietary internal system that is typically found more on the health plan side of healthcare, which is around care management. If any of you have worked in an EHR, you know how extremely encounter focused it is, right? The majority of EHRs are billing platforms. We happen to also document our clinical work in there, but is focused on submitting actual encounters for volume-based payments. We needed to create a system that would allow us to look at a member more longitudinally, that would allow our broader care team to communicate in ways that aren't just about dropping individual notes. And that's our system Commons. It is phenomenal. It is in every way where we're going to be expanding additional tech support and broader population health needs. It's where we're building in a lot of support as far as risk stratification, data analytics. That's a lot where our tech enablement comes from as well too. We actually have been using machine learning and a great deal of our algorithms to be able to identify whether it's claims-based data or not, who are the right members within our populations to actually direct to specific complex care programs or social needs or the like. So the tech enablement using our Commons system, we're now on Athena as far as an EHR, which has a very strong API, so we can actually attach Commons on top of that. Our tech stack as a whole really facilitates our ability to help the member. Then the majority of it is not member facing, but you never know in the near future. I mean, there's plenty of opportunity. And actually, we do have an internal behavioral insights team that does surveys of our members that we're going to start asking what other formats of communication would be helpful for them, whether it's an app or expanding opportunities through the portal and the like. At this point, we are focused on, honestly, which of our members need to physically be touched, right? And it may be in the home, may need to really be that source of communication and, again, earned trust. And so it's not so much about bringing that digital platform to patient-facing space, because our successes are really coming through the relationships, the continuity, really, that primary care requires.
So follow-up question then on that, what is your patient-facing portal, or is there one? Is that, is that an important part of your model or not?
It's not currently. It's
Wow.
not currently a large part of our model. We're going to be rolling out, turning on the Athena portal in different ways, but we haven't too quite yet. At this point, we are engaging at phenomenal rates without using a patient portal.
Fantastic. So lots of talk this morning about, how to provide social services in an integrated way to help meet, members' basic needs, and how that actually helps keep them connected with the health system.
Yeah.
As you look at your model and kind of the members' benefits that they've seen from, being screened, leveraging your community health partners to get people connected to services, and actually getting the services to help those needs be met, what are you actually seeing in the benefits of that from a member perspective? And, how hard is that to do
Yeah.
in practice?
That's a great question, a great way to frame it. I would say that our social care services, we just call it social care, like you would medical care, social care. We are doing so at pretty phenomenal rates because, first and foremost, we see that as the primary set of goals often that our members are placing in front of us. They are not worried about, usually at the same rate, what their screenings, whether they've completed their screenings or unless they're actually feeling poorly, they typically aren't as worried. As a primary care doc, I don't like this, but still, they're typically not as worried about some of their larger, physical disease-based conditions, as opposed to how they're actually going to pay for their next meal, how they're actually going to keep their electricity on, whether or not they're going to find that next employment because they just got laid off. And so oftentimes our community health partners, that first contact with the member is actually going to focus 100% on the social needs before they steer that member over to the clinical team. And that's appropriate in every sort of way. A whole health model is in every way focused on the priorities from the member's lens, not our own. And again, it's the medical model that's forcing us to, of course, we need to collect the data, but that's forcing us to really drive at every visit, every encounter towards medical outcomes, as opposed to the larger concepts of well-being that the patient defines. Thank you. So really, social care is embedded throughout. It is the beginning, the middle, and the end of our model. We definitely believe it is our lane, right? You often hear this about medicine. It's not in our lane, right? This is in every way within our lane, because we will never be able to address their chronic disease issues, the reason why they perhaps have higher acute utilization of the emergency department and inpatient, the reason why they're not adherent to their medications, all of these very medical sounding outcomes. We will never address that unless you actually acknowledge upstream their social needs. So we are extremely excited for the waiver. We are paying attention. We are eager to continue partnerships. I think God's Love We Deliver was sitting somewhere. There we go. I saw you guys. Strong partnerships such as this one with Unite Us, with Find Help. We, across all of our markets, really do believe in the engagement that obviously we have to have with our members, families, communities, but with the community-based organizations, because just because we may want to coordinate it and screen for it and the like doesn't mean we will physically be able to deliver each of those services. So we need partnerships. And that's where the concept of being a part of a health ecosystem comes in. As much as we stay one-stop shop, that is in every way limited. It's one-stop shop in that this can be an initial introduction in a way that we gather the information to figure out how to address needs. But there's a larger ecosystem over time, what we've called it medical neighborhood. I mean, there's so many different terms, but there's a larger ecosystem in which every single one of our members functions. And we recognize and are humble enough to accept sometimes our limited place in that ecosystem. So partnerships are so exciting. And so as the SCNs get designated next month, we're all keeping our ears to the ground, right? As those get designated, we are hoping to continue those collaborations, have partnerships, and be a part of the data collection first and foremost. I think that was one thing that stood out for me in the director's introduction this morning, the data collection piece, knowing what we have to go through for our data from our payer partners, from other partners, and how difficult that can be, whether it's in an HIE or ADT feeds, all this different technological stuff that I literally just learned, guys. But I'm lying, but it's still not what I learned in medical school. It's, all of these pieces, that is not standardized nor collected in a standardized way in the social needs space. And so for us to work together on how we actually do that and how we share screening data between each of the collaborating partners within an ecosystem, that's what I'm personally a bit nervous about. But we're ready for it. We're eager for it. And in fact, it behooves us in every way, because we have that full accountability for every member, to share everything we have, just as much as we're going to ask everyone to share everything we have.
So
They have.
you open the door on the waiver, but I also know you guys are in other states that have had waivers.
Yeah.
Emma's going to come up and, coming from North Carolina, headed to Oregon. What has been your experience in other states with waivers around, the health-related social needs, and what should we all be striving to learn from maybe what you've already gone through in some other states?
So it's been interesting to watch how the two waivers have developed in the two different states. We unfortunately weren't located geographically where the North Carolina waiver was applied, so it was very restricted. However, they've made the decision to move it fully statewide, and we're partnering with the state. We've met a couple times to really be able to lean in as much as we hope to lean in here. So I unfortunately don't have a lot of learnings about the waiver per se, but our partnerships, the way we collaborate, and the way that we consider the bi-directional data exchange is tantamount, regardless of whether there's a waiver. So we're looking forward to how this structure has been laid out.
So talk a little bit about how you've developed those partnerships, and how that might help us think about how we're all going to need to partner across this ecosystem going forward.
Yeah. I think this is just the old-fashioned grassroots. I know every single person in here has done some level of community organizing, knocking on doors, and having those relationships and partnerships. There's nothing more fancy than that. I mean, of course, Unite Us lays out a beautiful set of partners in front of us, but regardless of what it says in the screen, you're not going to really be able to accomplish any outcomes without getting to know the people in that organization, without having an understanding of where the support can go in both directions. So for us, really believing healthcare is local, we treat every market as if we are becoming a part of that fabric, a part of that ecosystem, and we build those relationships one-on-one. There's not really more of a digital approach beyond that.
Great. So we've got a few more minutes, and I can sit here and ask you questions all day, but I do ask folks in the audience and online to start thinking about your questions. Do want to circle back to that outcomes question from earlier. And, what is it that you're seeing in terms of either total cost of care or specific reductions or specific health outcomes that really, shows the value to payers?
Yeah. So we have been consistently successful around total cost of care. We are bringing down avoidable ED utilization, inpatient readmissions, initial inpatient admissions by upwards of 20 to 30% in some of our cohorts through our mobile integrated care program, through our chronic disease pathways, through our advanced behavioral health program. Again, we do not shy away from treating all patients with serious mental illness and converting them into evidence-based outpatient management, whether it's long-acting injectables, medication-assisted therapy for substance use disorder. We are decreasing behavioral health admissions by 20% as well as controlling chronic disease of those patients with SMI, as you all know, that typically do not have strong primary care follow-up for their other issues. Usually their behavioral health is the only issue that's addressed. We are improving HEDIS outcomes depending on the cohort, depending on the denominator of the metric. You know how the math is for every contract, it is different. We're improving HEDIS outcomes by 40%. And managing follow-ups, managing transitions of care. I mean, all of the standardized ways that we measure both financial and quality outcomes, we have made leaps and bounds towards. There's a dose response to it. The longer a member is with CityBlock, the better the outcomes are. So, you know, there is a glide path that we need to take as we take on new cohorts. But most importantly, along with those other outcomes, we're improving patient trust and satisfaction. We are actually starting to measure trust and satisfaction and currently validating our own tools. We're using NPS and CAPS and all of the other things that we're using, but we've actually combined them into a different tool and are validating currently, just because we wanted to get a little bit more into the nitty gritty and distinguish between trust and satisfaction in a provider, in an institution, in a care team, in CityBlock as a whole. And we're seeing significant improvements there as well. Because again, the success of our program, the success of our clinical outcomes are 100% hinging on the fact that our members actually want to work with us and believe that we're actually going to be able to assist them. So the member experience, the member trust, again, being rightfully a focus at the beginning of the relationship is really the utmost outcome for us, and we'll continue to push until NPS gets to 100 even. It's looking pretty good, and again, dose response with that as well. I think one of the more exciting outcomes that comes with this, and us being in this conversation around Medicaid, you're all acutely aware of the churn that is always complained about. But we don't hear policymakers fixing it. But the churn is difficult in Medicaid. We obviously, that continuity piece that maybe we can provide in primary care, it's difficult from a payer standpoint on many different reasons, both policy as well as personal there. We are actually seeing improved retention across our cohort. So they are churning less when they are part of CityBlock. And that in and of itself is obviously quite attractive to our partners.
Yeah, and given that you've got a dose response, that's important. What on the front end of that dose response are you seeing in terms of kind of where exactly utilization is increasing that may be leading to that longer term dose response?
You know, honestly, the initial activation with our community health partners is where the increase is. I mean, they may have those relationships even with a former or an outside primary care doc. But so much of, I heard this phrase a couple of weeks ago, so much of the need is in the interstitium. It's in between those visits. It's the communication. It's that larger concepts of care management and coordination that unfortunately the traditional healthcare system may not pay for. It may be disjointed from the primary care relationship. For us, just the sheer activation in taking part in any of our services, separate even from clinical disease management and treatment, is where the best outcomes are stemming from, because we earn their trust through those relationships, through that communication, so that they then are more likely to perhaps accept one of our recommendations, participate in one of our complex care programs, call us first instead of walking into the emergency room for something that's otherwise a primary care function, because they know we're available because we're reliable. So much of that interstitium is where the rubber meets the road, and where, I hate to say it, even in the VA, I mean, in the VA, we also pride ourselves on having that accountability for veterans and managing their end-to-end care. It wasn't always available. And at times, based on your medical center, it wasn't always consistent. City Block is aiming to address those issues.
So tell us what those community health partners look like, what training you have to do, how of the community must they be to be that interstitial tissue?
Yeah. They are strong communicators. So there isn't a picture perfect. And in fact, there's a wide variety of our CHV's backgrounds. They have to be strong communicators. They have to be advocates. They have to understand the community that they're representing. They, a large number of times, have to have some lived experiences. So it's not just about seeing, but actually having undergone. And then we build from there. I'm accompanied by my colleague Shoshana Brown here, who is building out our, and you all know her, she's done this. This is why we poached her a little bit. But this is where the rubber meets the road, as far as we building our own sets of competencies and trainings, really thinking about their career pathways, how they become more successful, perhaps as health coaches, or particular to specific chronic conditions. So we actually move some of our CHPs into senior CHP roles, particular to our complex programs. So our advanced BH program, which is again around serious mental illness, we have a subset of CHPs where that is their focus. So non-clinically trained, but managing our patients with schizophrenia, schizoaffective disorder, and the like, because they've become more comfortable. They know how to communicate. They are one of the main successes of that program. The other program, and unfortunately not available here in New York, but in our North Carolina market, we do, thankfully, the discussion in the last panel really drove this point home. We do see mothers and kids in North Carolina at a very high volume. And our CHPs are actually a huge part of our maternity program. They are all trained as doulas, and they are accompanying our members not only to their prenatal visit, because we actually don't take on their prenatal care. We have champion prenatal practices in the community that we partner with. And then we also accompany them to labor and delivery, and the clinical outcomes as well as the member experience is quite phenomenal with that program as well.
So you mentioned the lived experience of the community health partners, but you also early on talked about kind of this population often coming in with a fair amount of trauma themselves. How do you think about kind of training around trauma-informed care across the multidisciplinary team? So wherever this person is touching your system, they're really getting that, thoughtful trauma-informed care.
It's a requirement of training at the onset. When you enter City Block, when you onboard, it is a standardized approach, trauma-informed care, that we adopt within our workflows as we think about case conferences, and really thinking about at an individual member as well as at the population level, how can we actually address trauma, whether it's physically within our hubs, or remember, when we're actually going into the home, it is a very different environment where they still actually may be experiencing trauma, but yet we're entering this space, and we need to be very cognizant of that. We need to obviously address their own safety, both emotional as physical, as well as our staff members, right? And home-based care and the kind of staff safety around that is a large issue that we have built some structure around as well too. So for us, trauma-informed care is the baseline. It is not an extra concept. It is the baseline, right along with addressing social needs, integrating all of our clinical services.
You talked a little bit about kind of your own workforce and, the retention, the lack of burnout that comes from this model. What do you think is the secret sauce behind that, other than seeing the difference that they're making in people's lives? What else is it about the model that makes it a model people want to work in?
Yeah. Well, I think it takes a specific personality to first want to come to City Block because I mean, even I got asked when I was leaving the VA, right? The biggest bureaucratic federal agency that we have. And they're like, you're going to a startup? Like I literally went to the other end of any financial schema. But even I got asked, and others are equally as questioning, like, oh my goodness, you're going to a startup? Oh my goodness, it's venture capital supported. Oh my goodness, it's what if it's not gonna be there? We're gonna be, trust me, we're gonna be here. But part of the personality that it requires is acknowledging that in coming to a startup, it's a bit different. It is not your structured health system where maybe it's going to take 6 to 9 to 12 months to change a policy and to do like, we literally, and I've done this to my teams, unfortunately, come up with a new idea and we're going with it in a week, you know? So it takes a personality to be able to adapt to change and to acknowledge that we in no way have it perfectly yet. And in fact, I have lost providers and nurses and the like over time. And you know, our alumni, we have alumni in the room. You know, our alumni may not have always had the best experience, and we understand that, and we hope to gather that data and to iterate on the model. And I believe that we've done so. And I stand fully accountable for continuing that effort. I think not only the startup mentality, and I love change. So this for me is like where I thrive. I don't like kind of the static inertia of larger health systems. I think in addition to being ready for change, we are also trying to prove that we have a strong business model, right? That's why we are supported by mission-focused investors that believe in us. This is why we're continuing to grow. So now we're at 7 states. I heard a number thrown out there last week that we're going to be growing even more over. I'm not going to share the number. I know the number. I'm not going to share the number, but over the next year, we're expecting more and more states. So part of what that requires is a level of efficiency that means you're not going to get that next FTE. You're not going to get these additional resources. We're not going to get that new tech solution and the like. Right now, we have some priorities that we need to direct resources to. So how can you be scrappy? Right. And we've worked, I mean, anyone who's worked in a FQHC, we know how to be scrappy, right? I was rooming my own patients at one point. I didn't have an MA or an RN or anything. I was just doing the whole thing. And that's what I believed in. And that's what my patients needed. Sometimes in City Block, as much as we love to say we're a fancy solution, sometimes it's just bread and butter, scrappy medicine. And so you have to balance that. And sometimes that can be frustrating for some of our clinicians. I get that. But I think overall, they are enjoying the fact that we're approaching medicine, the model, healthcare differently, and that we're going to continue to try to be a part of the solution as opposed to sitting back and complaining about the problem.
That's great. Well, folks, get your questions in. I have one final question before we move on. You talked about it. You're a startup. You're VC backed. You know, you're working in a very disjointed, you know, regulatory and broader healthcare ecosystem across 7 different states. Besides scrappiness, what's it going to take for models like this, for City Block and beyond to bring these to scale?
This work is hard. And every single person in this room and in the Zoom knows how difficult this is, how it takes hours of your time and your emotion. However, we all do it every day. Many of us in this room have done it their whole career. And so for me, what it actually takes is just the commitment that we all have here. It is hard, but it can be done. So having leaders out there that are willing to make these hard decisions, that are willing to found or transform or partner or whatever big fancy verb, to be able to move away, just resist inertia, right? It takes the leaders to be able to do that. That's what our founders did. They saw a need and they stepped away and really just made a decision. Now 7 years ago. And that's what it's going to take. It's going to take leadership. And it's going to take, I think, the mission orientation of whatever entity is actually accomplishing that, right? So we obviously are trying to prove a business model. You need funding to do that, right? And so that's always going to be a part of the question. But having a larger purpose, a real vision of what you're trying to accomplish is a necessary piece as well.
Fantastic. Well, having now been a decade in New York, I think we are lucky to have leadership, commitment, and
Exactly.
mission.
Exactly.
So to me, that just sounds like Dr. Matthews told us we can all do this. And I will charge us all with doing so going forward. But first, want to make sure we have time for questions. Folks in the audience, please feel free to come to the mics. And Alexis will moderate questions from the Zoom.
Yes, thank you, Chad and Dr. Matthews, for that inspirational discussion. I can kick us off. So you discussed regulatory barriers in New York State as it related to, oh, sorry, Dr. Series.
No, please.
Go ahead. Okay.
I'm short.
You discussed regulatory barriers in New York State as it related to practice authority. What has been your experience with the telehealth landscape, New York State or nationally, public health?
No, great
emergency?
question. And I was just having a conversation about this last week. So the pandemic, of course, released a great deal of restrictions around licensing. It helped us to pivot, as many of your organizations did, quite quickly. We otherwise license in every state, so it hasn't necessarily been a barrier that post-pandemic, the telehealth restrictions about licenses have been pulled down. We're fine. Like I said, I don't know how many licenses at this point, and we do the same across most of our docs. The one limitation that we currently have is not so much around licensing, but around DEA standards, and how with controlled substances, particularly around buprenorphine, medication-assisted therapy, there's an in-person requirement. We actually have been quite successful providing medication-assisted therapy for substance use disorder, opioids in particular, through virtual provider visits, perhaps having our paramedics in the home to assist if there's questions and the like, or a nurse in some cases, even there to help with administration and the like. That's one of the major limitations, because I'm able to cross-license and build teams. Sometimes just for efficiency, I may not have a provider physically located there to help with in-person care. So that requirement, we really think restricts the capabilities that virtual health otherwise opened up for us. So we really are advocating for removing in-person restrictions. Of course, when clinically appropriate, but that should be our call, not a restriction by DEA.
Thank you.
Great. Thank you for this very engaging conversation. So, Dr. Matthews, I had the privilege of visiting with you at your Brooklyn hub, and I was really blown away by the model. I'm hoping that you can talk with us a little bit about the flexibility of the model when you're the PCP and when you're not.
Great. Yeah, I didn't touch on this at all. Thank you, Dr. Barbeau. We have the ability either to accept attribution from our health plan partners as PCP. So we are the full end-to-end primary care practice, providing all the social needs, addressing acute utilization as well. But oftentimes, and in fact, the majority of the case, we are not the assigned PCP. And we are okay with that. Oftentimes, our members have a PCP in the community. In fact, our New York hub is mainly this, a wraparound model, as we call it. They have another PCP, but that PCP is often, again, in that fee-for-service environment. Unfortunately, not due to intent, but just due to the reality of their environment, not able to meet that member's needs holistically. Oftentimes, I mean, I practiced there. Again, I was in a clinic where I was rooming patients myself. I didn't have a nurse care manager, right? So we'll offer care management to be able to think through chronic disease management, self-awareness and self-management skills, teaching around nutrition and diet and the like, all of lifestyle medicine, all of those pieces that need to be adapted into chronic disease management. Sometimes the PCP visit alone, remember that 15-minute visit, you aren't able to accomplish there. So our extension of primary care, as we also call it, we think is really the way to address the shortcomings of where we often see PCPs are limited in their current business models. Our clinical pharmacy program, our psychiatry, all of that typically additive to another PCP's relationship. It's then on us to assure that there's communication with those care teams, and that is critical. And that we will continue to iterate on. I'm hoping to actually get the PCPs that we work with access to our common system so they can even see the full care team management and how it's working. That's a step in the future. But one of the biggest issues, and I had to get over this because I'm of the PCP, you know, I was trained, I was like, oh, we can do everything. Yeah, we can, but we often can't. That's part of the problem. And that's where our patients fall between the cracks. So if we aren't able to do it, what if you just had another practice that was going to be fully accountable that could step in and fill in those gaps? That's really our goal. And so part of what I also like to promote with that is, therefore, when we enter a community, when we become part of a new community, we're also not there to poach the other PCPs. Because when a new primary care practice opens, they need workforce. Where are they going to get them from? Probably from the other practices. So our goal is not to come in and poach and disturb the ecosystem, but it's come to fit in to the gaps that unfortunately are there.
Love the model, love what you're doing.
Thank you.
One of your comments you mentioned about sort of starting where the member is, where the patient is, right? And then meet the needs and then sort of build. And one of the things that attracted my attention when you were talking about access to long-acting injectables.
Yes.
So one of the great things about your model is that people probably who are out of care with high needs
Yes.
get walked back into care in a
I
way
know
that
exactly
feels
where you're
right for
going.
them,
Yeah.
right? And in the process of that, right, if
go up.
you're raising screening scores, you know, the quality metrics where you're identifying things and then you triage and you prevent higher costs, costs actually go down.
Yeah.
But in the comments about long-acting injectables, I think about behavioral health and HIV meds, right?
Yeah.
And then you identify other things that's going on in the human body and you sort of help people. Costs will go up,
Yes,
in the
they do.
short run.
In the short run.
And so this is an issue for providers in terms of value-based payment, right? If we do what we need to do with the 25% of people who cost 75 cents of the Medicaid dollar, it's actually because they're not getting the right complement of care.
Exactly.
Right? And we end up paying more in the long run.
Yeah.
So how do you deal with that complexity of value-based payment? Because I think a lot of providers want to do this.
Yeah.
Right. But if the answer for government is one size fits all value-based payment, I think the uptake, first of all, the providers don't have the private equity dollars to invest in the
Venture
model.
capital. Yes.
Venture capital, sorry. So how do you think about that complexity? Like, is value-based payment overplayed? Or do we need some other tools or levers to make what you're doing more scale?
Brilliant question. First and foremost, on that latter part, I definitely am learning this business as well. I know a good amount, but there's still plenty more. I don't think we nor anyone should ever tout that we're the single solution, right? That this is the only way to accomplish transformation. But I do think it can be successful. And I think getting to your point around increased costs basically for deferred undiagnosed care. Remember, that was a huge concern we had immediately after the pandemic, right? All the deferred care and everyone's costs would increase because they were getting delayed diagnosis, particularly around cancer. Women weren't getting their mammograms and the like. For us, if you look at it over a population level, yes, an individual patient's costs may increase, but over a population level, we're actually managing that acute utilization on the reactive end such that we actually are decreasing cost over time across the entire population. So it's not so much about calculations at the individual member, but because I'm shifting, to be honest, I'm shifting the care, let's say, for that patient that needs the long-acting injectable. I'm getting them in the outpatient management. And one example I can think of off the top of my head, he was going into the behavioral health emergency rooms 13 times a year. So the increased pharmacy costs, that's the other thing, you have to look at the cost holistically. So while the pharmacy line might go up because I'm getting them onto a somewhat fairly expensive LAI, I'm decreasing their acute care utilization over here by significant amount. So we have to look at it holistically. And so that's where we're looking instead at kind of MLR and the like, and not individual lines of costs. That's where we actually look, however, to look at our interventions. What more can we control with our analytics? But as a whole, I still do think even with smaller practices and the like, that there's plenty of opportunity to manage the population. You do have to build the interventions though to respond holistically. So if you are increasing outpatient management, but not making an impact on other costs to the system that may be occurring, then of course your costs are going to go up.
And maybe value-based payment needs to evolve, particularly in dealing with high needs, high costs at the zip code level.
Yeah.
To really, like, if you're increasing outpatient utilization, you're actually doing really good work, even if the total cost of care doesn't go down. And I think we could use some of
But I
that.
think total cost of care will go down. It may not be on a timeline that we're initially looking for as far as short-term ROI, but our total cost of care is going down even within the first 12 months as we're increasing outpatient management.
Thanks.
Yeah.
Thank you for your presentation. Very enlightening. I know there will obviously be a lot of changes with the waiver, but how do you think about your partnerships with CBOs and in particular like funding and right sizing the kind of funding so that they have the capacity to respond to the demand for social services?
Yeah, no, I mean, so the CBOs we would work with, the ones we do work with, if you're not currently receiving direct funding from us, you would otherwise be receiving funding through the SCNs, through the fee-for-service, fee-based sort of model that was shown earlier. Now it's through partnership. Now it's working on, their mission-oriented approach to helping members in the community. We otherwise aren't funding a lot of those social needs other than the groceries that we're buying and the like.
Does the payer fund any of those partnerships?
Not
between you and
currently,
the
no.
CBOs? Okay.
Not currently, no. So the SCNs are pretty critical so that we can actually get better resources to our partners. Yeah.
Thank you so much. One more round of applause for Dr. Matthews and Check.
So hi, everybody. I'm Alex Brandis. I'm the director of the Medicaid Institute at UHF. And I, as a native Oregonian, have the distinct pleasure of introducing our afternoon keynoter, Emma Sando. As we've said throughout today's session, you will mostly recognize her from her very exciting work in North Carolina. But please come on up, Emma.
Thank you so much. As hopefully has been mentioned before, this is my day 6 as Oregon's new Medicaid director. In every other government job I've had, they usually don't let you out of the building until 6 months in. So, but we're here, and if it weren't hard, it wouldn't be Medicaid. So I'm hopefully going to be caught up enough on my new job. But I will warn you that I'm still very much my last day in North Carolina was 7 days ago. So if I refer to y'all as y'all, I'm sorry, I can't take that out of my vocabulary just yet. And also y'all is one of the best ways to refer to a group of people. So I am also very happy to be here, happy that you all are here. I am shocked that you're awake and alert, given that yesterday you probably spent the entire night celebrating Medicaid's 59th birthday. I feel like today should be like the day after the Super Bowl with just a national holiday, but here we are. And if you did forget Medicaid's 59th birthday, you have 364 days to get ready for the big 60th. I have used up enough time of introductions to get to the content here that we're talking about today, which is our 1115 waiver in Oregon. I'm going to talk a little bit about what Oregon generally, give you a little bit of background on our Medicaid program, where we've been over the last 20 years or so, as well as a deeper dive into the health-related social needs 1115 waiver that we are currently in the process of implementing, and get a little bit deeper into our engagement process, which is so crucial to this work. So, before I begin, I do want to really call a specific attention to what our program is, and a bit more about our health equity goals in Oregon. So we have a program of community governed organizations, which we refer to as a coordinated care organizations, or CCOs. They bring together both physical and behavioral health and dental services, and provide coordinated care for Oregons across the state. These CCOs have been in existence for a number of decades here in Oregon, we've really evolved them over the years. We had CCO 1.0, we're currently in CCO 2.0 version. And the goal really is to make sure that we are including all all people in the process, so really focusing on the community. So we do a blended budget, which grows at a fixed rate and includes all the physical and behavioral health care for our members. We also include incentives for our CCOs to invest in our members and improve their health outcomes. The CCOs have flexibility already, and have had flexibility over the life of the program to address members' social needs, but we've really ramped that up over the last several years with the addition of the 1115 waiver. So Oregon's health equity definition is to ensure that all people can reach their full health potential and well-being, regardless of various demographic groups that they belong to, whether that be race, ethnicity, sexual orientation, disability, age, social class, or a variety of other intersected community and identities, and other socially determined circumstances. We're working across all parts of government, whether that be state, local, or other entities and communities that are in the government, and our intergovernment relationship with our many tribes in the state, to ensure that people are getting these health equity goals achieved, and that we are redistributing resources to those that have historically been out of power, as well as rectifying injustices. Oregon has a goal to eliminate health inequities by 2030, and that's a very ambitious goal that this health-related social needs program that we have is really working to address, because as we know, health inequities and those social drivers of health are so closely intertwined. So our 1115 waiver. For those who have been sitting through this conference and aren't familiar with an 1115 waiver, I feel badly that we haven't explained it yet. But it is a waiver of Medicaid law that allows states to change specific parts of Medicaid law, whether that be eligibility or certain benefit structures, or other ways in which the Medicaid program provides services to the beneficiaries, in order to improve the health of the beneficiaries and meet the goals of the Medicaid program more broadly. The federal government provides this permission to waive or change the program after a state's request. And those waivers can be as small as just a city-specific program that focuses maybe on one particular maternal health population, to as broad as the entire population of the state. And we have gotten a variety of wonderful changes through the 1115 process. In Oregon, we did a lot that led to what would become the Affordable Care Act, even though Massachusetts also takes credit for that. This really provides an opportunity for states to test new innovations and for different states to compare how they implement these a variety of different things so that we can see what potentially would become the best policy for different states that have different types of populations, different types of provider entities within the state. So it is exciting that we've got so many different states here with New York and North Carolina theoretically in the room, and Oregon that are all working to test different ways of providing health-related social needs so that the federal government and more broadly the health policy community can learn and grow. And that really is fundamentally what these waiver programs are meant to do. There we go. All right, so what our 1115 does. We actually have 4 1115s. I really, every time you talk to a state and they talk about their 1115, good question is how many 1115s do you actually have? They do a variety of different things sort of all together through a number of different programs. So we have an extension of eligibility for young children and youth and adults. We have the continuous enrollment and continuous eligibility program for children up through age 6, and then additionally, the 2 years of continuous enrollment for other health plan members over the age of 6. So I know that New York is beginning to implement that continuous enrollment for up through 6, but also that 2-year period, I can talk a little bit more about how important that is to reducing churn, of which we are working to try to address churn, as was mentioned earlier, as much as possible. I'm going to really dig deeper into the health-related social needs, the HRSN supports that we have. We focus on housing, nutrition, and climate services. The climate services, as a spoiler for a couple slides from now, are in effect, and we are working to get those housing and nutrition services coming online as we speak. We also have a new program that covers young adults with special health needs up to age 26, so that we have that continuation of coverage rather than having a sort of drop off of enrollment. And this is up until 305% of the federal poverty level. There are another set of 1115 waiver approvals that we just received, and as well as a number of other states to provide Medicaid services for people that are in carceral settings 90 days prior to release. This is separate and apart from the omnibus bill law that requires services for youth who are in carceral settings at or right before release. So our HRSN program. So the health-related social needs are the social and economic needs that impact a person's ability to maintain their health and well-being. So you can really see how closely this ties to health equity and how important this aspect is to ensuring that we can achieve our goals of eliminating health inequities. So we will be providing services for climate-related needs, as well as outreach and engagement. I did not mention that earlier. This is in part to make sure that people can access those health-related social needs. So if there's barriers to being able to get those HRSN services, as well as ensuring that people are engaging in other aspects of the social services programs that the states, counties, and other partners provide, because oftentimes Medicaid can be a pathway to ensuring that those other programs such as SNAP or local entities that are providing services for people are able to be utilized, because oftentimes those are underutilized as people that are eligible are not participating in them. So we have the housing supports launching in November, followed by the nutrition supports. So a little bit more deeply into this, as you all likely have heard, Oregon has experienced quite a number of climate-related moments over the last several years. Particularly, I'm thinking of the heat dome that caused temperatures to increase dramatically, and many health effects resulted from that a few years ago. And so the importance of making sure that air conditioners and air filtration devices are in place, especially with, I believe, the largest wildfire in the United States that's active today is in Oregon, and making sure that people have access to these can ensure that chronic conditions such as asthma or other health-related needs are being served, and even in those climate catastrophes, people have access to services to ensure their health. But there's a lot of other things that a climate emergency can prevent one from being fully healthy, such as the need for refrigeration or of medical supplies and that sort of thing. So these climate-related services are really providing things to people, is how you can really think of it. I'll get more deep into housing momentarily, but the housing is built on being the transition between a situation in which somebody has housing and or is in an unstable housing situation to having more stable housing. Medicaid is really part of the patchwork of the broader Oregon quilt of housing-related services, and Medicaid can't be the long-term housing provider when many of those programs already exist to make sure that people have access to those housing services. But it can be that transition to make sure that that a person isn't put in a place where they would it potentially become homeless or without stable housing. Nutrition services are medically tailored meals for specific health conditions, groceries, hot meals, produce, et cetera. And those are coming online shortly. I'll give you the timeline here. So we have a phased approach. We've got the 4 phases shown here. First, those climate services, which have already launched, followed by housing services, which we are planning on launching in November. And then next January, those nutrition services. Timing TBD on additional populations to receive those housing services. We're starting off with a smaller set of folks at the beginning, as housing is quite complex and something that is really, really important. I don't want to understress how important a phased approach is to an 1115 waiver. 1115 waivers are really, really helpful for learning, because you're doing something that the agency likely has never been in the business of doing before. Figuring out how to work more appropriately with community-based organizations, figuring out what the barriers are of why people aren't using these services is really, really important to ensuring that these services are provided appropriately and well, and that they are ending up in the hands of individuals. So one thing that we really have learned is that within each phase, it's not a light switch necessarily of you turn on the services and then suddenly everyone arrives and starts receiving services. For example, with the climate services, for the first 3 months, we had 1,000 air conditioning units out to beneficiaries, and in the 4th month, we had 1,000 in that month alone. So it really ramps up slowly at the beginning as people become used to providing those services. And I can say from my own personal experience in North Carolina that was really the case as well, is that as each service came online, it took a little bit of time for people to fully understand how they can access those services, that those services are available, where to go, the various intricacies and details that needed to be worked out with the community-based organizations to ensure that they could get those services to people, et cetera. So having that phased in approach allows you to focus on each individual service area at a time. And something that we've really learned has worked well in North Carolina and thus far in Oregon. So who can receive HRSN services? This is the general eligibility criteria. So first, you do need to be eligible for the Oregon Medicaid program more broadly. And then for those that can receive HRSN services, you do need to meet these particular criteria. And those criteria are outlined in our special terms and conditions with the federal government. So we have a really structured criteria. But then after a service, you qualify for one of these services, you do need to meet that clinical factor as well to be eligible for the individual service. So you first need to meet the HRSN eligibility criteria and then the clinical criteria on top of that. So it's not every Medicaid member is automatically eligible for services. They both need to meet the needs criteria as well as the clinical criteria. So as I mentioned, the climate services, this really focuses a lot on what specific climate emergencies exist in Oregon, as it is a state that has experienced significant heat and wildfires, and these are really meant to respond to those climate needs. So when I talked a little bit about generally you need to be first eligible for HRSN, we've also sort of adjusted that criteria for each of the individual services. So same or similar criteria, but slightly adjusted, specific to the climate needs. So for example, individuals who are homeless are included in the climate criteria. And you might be wondering where a person who is experiencing homelessness would put an air conditioner, for example. But I do want to remind folks that if you're living in an RV or another situation like that is meets the definition of homeless oftentimes, and therefore some of these services can be provided for those individuals. And it's tailored specifically. We're not going to provide an air conditioning unit to somebody who isn't living in an RV, for example, but it's tailored to the individual's service in particular. So that's how you can adjust the criteria a bit to meet the needs of the specific service that is provided. And that flexibility really, really is key. So I'll talk a little bit more about housing-related services. These are the services that are provided for housing, and what you'll really see is that it is focused really on that transitional housing. Governor Kotek's top priority is housing in Oregon, and we know that it is an area that we're seeing across this country, and especially with Medicaid members, that there is a really large need for housing, and that moment of being unhoused, it really does cause a significant health change and oftentimes for the worse for folks. So addressing that prior to that housing instability event, so that a person can have stable housing for the length of that they are receiving healthcare services, is really, really crucial to health, and it's really closely correlated. So so a lot of these particular services are making sure that a person, if they're in an existing housing unit, can maintain that housing unit. And if they are falling into that HUD definition of at risk of homelessness, that they are receiving services so that they are no longer at risk of housing and urban development definition of at risk of homelessness. We estimate that about 125,000 Oregon Medicaid members are at risk of homelessness in that HUD definition. And that HUD definition has three components to it. It's that your income is at least 30% of the average median income within the area. You don't have any family resources, and that you're either returning from an institution or 50% of your income is spent on rent. So that is a very high bar for at risk of homelessness that the housing and urban development definition does include. However, there are still quite a large number of people that we estimate are included in that large or that narrow definition that the federal government put out. So again, we once you do meet that criteria of first being a Medicaid member, then being eligible for the HRSN services, and then having those clinical criteria, you also here's the housing criteria that we are using for that 11-1 launch. So we're focusing first on those who are currently housed or need to maintain current housing and meet those criteria outlined by the HUD definition. And so the clinical definitions that I've kept referring to, these are also outlined in our approval with the federal government. They are focused on complex behavioral health conditions, developmental disability, physical health conditions. While this might feel like it includes most all of Medicaid members and people that are enrolled in the program, there are quite a few people that don't meet these criteria and would not be eligible for those housing services or other HRSN services in Oregon. But it is quite broad, and the federal government worked with the state very closely to ensure that we're making sure that people do have as many clinical factors that affect those health-related social needs and are closely intertwined as possible. So I am not entirely sure what New York refers to their community capacity building funding as. North Carolina refers to it as our capacity building funds. But these funds support the entities that will be service providers for health-related social needs to essentially get them prepared in order to be able to provide services once those services are launched. What is really important here is thinking back, and this was really discussed a bit earlier today. It is not typical for community organizations to work directly in the medical world, the billing systems, billing processes, IT technology, just the way in which funds flow in general is very different in the medical space in comparison to what many community-based organizations are used to. Oftentimes, community-based organizations get a grant. They know how much money they have for their financing. They know how many people that they can hire, and they know the length of that period, and things are pretty well known, and they can work with a lot of flexibility within that grant itself. With having a billing system where you're billing for each refrigerator provided, or sorry, each mini fridge provided, each air conditioning unit, each housing service that is successfully provided to a person. It's not the same sort of way in which you are providing those services, and your budget is being developed. So these capacity building funds are really crucial to hiring up staff or allowing community-based organizations to hire up staff and to get the IT technology needed. Well, I guess I said technology twice in that sentence, but get the technology in place so that they can bill, so that they can speak with the CCOs well, and have all of the appropriate resources that they need so that they launch successfully. Here's a little bit about what in Oregon the capacity building funds will go toward or are going towards. So I mentioned technology, also those business development processes. So designing new workflows, a variety of different plugging in where different units within a organization will plug in is really, really an important part of this as well. And recruitment and retention, it is a very hard time to be hiring generally over the last several years. And so additional funds to support those recruitment and retention efforts and workforce are really, really important. And then we also are very, very have a very, very important part of our process is engagement with the community. I'll touch in much more detail about what we as a state are doing, but we do encourage all of our community organizations to also bring the community along and involve the community in this process. So we do focus on some of that outreach and education support so that that people know that they have these services available to them, and that we build trust within the community that and the voices of the community into this process. One thing, just a little off script of my experience in North Carolina, and I am more than happy to take questions if you all are wondering what is going on in North Carolina. But the flexibility here on the capacity building funding is very, very important because as I talked about a little bit with the phased approach, you often don't know what the barriers are of why services aren't getting to people until you're working through it and you're in the moment, and allowing flexibility for the capacity building funding. For example, North Carolina has the second highest rural population in the country, and many of their pilots were in those rural portions of the state. That is a challenge that community-based organizations have to overcome to make sure that they have the refrigeration equipment to be able to provide healthy food boxes to rural place, because when it's 100 degrees and you're trying to bring vegetables 200 miles to a beneficiary that lives out in a rural community, you do need a refrigerated vehicle, and that might not have been necessary for a community-based organization when they weren't having that scope and that reach before. So this here is really, really crucial and really important to maintain sort of the ability to be flexible as much as possible here so that community-based organizations have what they need. So we have done in Oregon quite a bit of engagement with the community. This is a little calendar of how much we've engaged. I'll remind you that there were only 29 days in February this year, but we did 42 engagements that month. A lot of these engagements were focused in the housing space, as that is a really, really crucial area for Oregon. But we did have many, many nutrition supports, community engagements, as well as those climate services engagements as well. We know that provider readiness is really important. So we really tried to focus on making sure that those groups that would provide services know how to access information. So we held trainings, work sessions for each of the different the different portions of the HRSN, as well as created fact sheets and other tools. And I'm very excited about we've got all of these provider journeys on our website in English and Spanish, as well as member journeys, so that members know how to access services, what they need to know in order to work with their CCO to receive these services. So we've got this website here. I am going to give you a cheat sheet momentarily of where all of these websites are located so that you can access it without having to go to more than one site. But before I do, I'm just going to wrap us up here and talk a little bit about the lessons learned in Oregon that you can take to your implementation in New York. First is, and I think I've said this a number of times now, how important the phased-in approach is. You really learn from that iterative way of releasing services that the different processes of what the barriers are, where you can improve IT infrastructure, et cetera, so that the next launches are more successful than trying to launch all the different services right at the same time. The screening process will inform our housing screening process, but we do need to make sure that we modify as appropriate for anything that we are seeing around utilization of the screening process. I know that that is something that requires a lot of community trust, and a lot of that community buy-in, as well as education of the community about was focused on the screening tool, because the screening tool is so key to making sure that we know who needs these services and where the need really is. And so getting that community buy-in is crucial, and then iterating on it for those next services. Just a note that trust is so important because it takes so much courage to be a Medicaid member and let people know that you need certain health-related social needs. That's not a typical thing that Medicaid has been involved in the past, and respect for that courage that it takes for the member to provide that information is really, really crucial to a successful launch. The support for HRSN from partners and providers is really, really important. That's why I emphasized all of our engagements. If we don't have buy-in from the broader community, then and trust in that and in building those relationships, it will help. Or we couldn't get to the next stage of launch, the existing relationship that we've had with the HRSNs for a number of HRSN service providers for a number of years through our various CCO projects that we've had in the past. This isn't our first go around with our CCOs really integrating with health-related social needs. It was allowed us to have more of that buy-in from the beginning. And if starting totally fresh with managed care organizations, not having those connections, it's going to take more work to make sure that those community groups and broader partners within the community understand the goals of these HRSN services. And then just a note that Oregon did get quite a bit of what is known as DSHB, the Designated State Health Programs fund infrastructure dollars to fund particularly the capacity building. I don't know where the federal government is in other waivers on that. So I'm sorry that if if New York did or did not get those fundings, but those were crucial to the success of Oregon's program thus far, and those infrastructure dollars are very, very important. So I think I am supposed to open it up to questions.
Great. So anyone with questions in the room can come up to either of the mics at the front and we will take those questions. I will start with a question from the Zoom. So there was a recent article that profiled California's HRSN efforts that noted only a small fraction of eligible patients have received benefits. How is Oregon tackling this challenge, or how did North Carolina facilitate uptake of these HRSNs?
Yeah, so as I mentioned, the uptake for is it working? The uptake for a lot of HRSN services has been shown to be a bit slower in the first little bit as the program gets underway, because this really is not typical. And I think what is really, really important is asking the questions of why the individual, examining every single detail from the eligibility process to the service delivery itself, of where there may be roadblocks or things preventing services from getting in the hands of individuals, whether that might be the criteria is too narrow, so there's actually no people that qualify for the various clinical and social needs screenings, or it may be that the community-based organization is not connected with the provider that is asking this particular questions, or whatever the there may be, and alleviating as many barriers as you can along the way through first starting with some of the more straightforward things, such as getting air conditioners in the hands of individuals, can help you sort of figure out where those kinks are and where that might be. For another thing, it may be that the weather is perfectly fine for a while, and people don't need various heat-related services. And then we go through a heat wave, and suddenly everyone those services are much more in higher demand. So looking at what the factors are that really go into getting those services in the hands of people is really probably the most important lesson learned.
Hi, I'm Meg Murray from the Association for Community Affiliated Plans, and we were one of the main champions for continuous eligibility for kids, and are thrilled that New York and Oregon are both going even further for up to 6. But one of the things we started hearing a little rumblings about are some concerns that, just like with unwinding, there were people on for 3 years who were not in the state. And so, the state was paying plans who I represent were getting funds. And I worry a little bit about the continuous eligibility for kids for so many years, whether there's going to be a backlash because some of those kids might have moved. Of course, we're still 100% supportive of it, but I just wondered if the state was thinking about how to ensure that those kids, their income won't matter, but their eligibility and residency does matter.
Yeah, I think we're doing Medicaid wrong if we are only contacting beneficiaries at their renewal, and that is the only interaction that the Medicaid program is having with a person over the course of the life of their enrollment. And we've really learned from unwinding all of the different mechanisms that we can use to contact individuals and to make sure that their information is updated, both through all of the various USPS moving around, as well as contacts with our external states. So if somebody moves out of state and receives Medicaid in another state, we immediately are aware of that. As with the public health emergency, there's those same criteria of ensuring that Medicaid is not paying for people who may have may no longer be alive or may no longer be in the state, and that those same sort of criteria apply to continuous enrollment, of that it's not necessarily that you are PMPM is being provided through the entire time. You are checking on those fundamental checks that we have done a better job at being able to match our data systems to. But also, we should do better as a Medicaid agency to ensure that that people are active in getting their primary care appointments, getting the regular services they need, especially for kids who do need those regular visits. Thanks. And in that, we can update all the data as well.
So I'm pretty sure that both Oregon and New York oppose workforce requirements. But I think there's maybe a unique opportunity here around addressing health-related social needs, maybe to actually create some workforce innovation and create jobs for people with lived experience, beneficiaries who've navigated the Medicaid system, figured out how to be well and utilize. And so one of the biggest health-related social needs really is economics, jobs, right? Do you think there's an opportunity for almost like the workforce innovation around, maybe we don't need to pay master degreed social workers or CASACs to go out and find people and help them navigate. What about beneficiaries, people who've already done that? Do you think there's a job opportunity here to really help people move from being under-resourced human beings to actually having gainful employment and living wage jobs? Do you think that's possible here?
So a couple of things I would bring up is that Montana has made a lot of efforts in this space, sort of in at different points, to connect many of their Medicaid members with workforce opportunities. And I know that that's something as part of the North Carolina Medicaid expansion legislation that North Carolina is pursuing as well. It's not a work requirement. It is a work or connecting more people to work who want to pursue work and are able to pursue work. But I think what's really, really crucial to any conversation about work is the aspects of equity. In not everyone has the ability to work or has other commitments due to whatever social circumstance that they are facing. And without creating any of these programs without a real focus on equity and making sure that we're not creating additional disparities by connecting people with other social services is paramount. And we can't do any of this without first thinking of all of the various situations in which a member might be encountering on a day-to-day basis.
And even for states to provide some flexibility. So if this new workforce kind of entered and you provide ongoing Medicaid coverage where, because people might have part-time jobs and not have health insurance, right? But I actually think government could innovate here to create the opportunities for living wage work, not a requirement, and then help people maintain their benefit until they get a couple of years underneath their belts and they could grow their income. We actually, this could be something that lowered Medicaid spend in some ways and actually created health sustainability by people having jobs and economic resources. So we're really curious. I know Care Oregon is doing some of this work in your new state. So we're watching very closely.
Great. I did forget to mention one of our 1115 waivers, which we are borrowing from, or part of it is being borrowed from New York, is we are very excited to be participating in the basic health program. And in particular, we got a waiver for our tribal population so that they can still have that choice as at those higher incomes, but really having that full continuum of options available to people so that continue to be insured, because we know that healthcare coverage is often not provided at some of those lower wage jobs, even if they are greater than Medicaid eligibility.
Hi, good afternoon. I'm Rebecca Wallach from NILAG. I'm thinking back to one of your earlier slides where you were going through the expanded coverage and the continuous coverage that you have in Oregon. And we've talked a lot today about churn and how excited we are about 0 to 6 continuous coverage. Can you talk a little bit more about the 2-year coverage for all Medicaid beneficiaries over 6?
Yeah. So I could talk a little bit about it, but
Again, day 7.
Still day 6, not 7 yet. I do want to point people that are interested in this topic to a couple papers that were actually written by professors at Duke, and they have a ton of different fact sheets up on their on the Duke Margolis website about these papers if you can't access because of journals being preventing barriers to seeing the full article. They've got a ton of other resources up on their website about this research that they did of the Medicaid population, and they specifically looked at churn both in the youth and how that affected health for youth. And really the argument that New York and Oregon have been making around how important continuous and coverage is for children, but it also examined the adult population as well, which not a lot of churn articles really have done, is looking at how care continues to be delivered when a person has that full continuum of care versus getting dropped from coverage, and then thus not having that chronic conditions really being fully taken care of in a way in which you eventually hopefully see some of those benefits of the investment in people's health. Those, when those get interrupted by a loss of coverage, then that person's health can deteriorate, and then those investments cannot necessarily be seen, or those investments might not be made because people know that that person may only be enrolled for a short time, since we do have such high churn rates. So if we reduce that churn and make it so that you can make those investments in a person's health and see the results, then hopefully we'll see more investments in those primary care and chronic condition management programs for adults as well. And hopefully, if we've got more continuous enrollment for kids, we'll see fewer chronic conditions later in life, because we know that when you take care of chronic conditions early in childhood, that has repercussions for the rest of people's lives. So it's all working together to really just improve health and reduce the burden of chronic conditions.
Great. We'll ask one last question. You listed numerous partner engagements and talked about how critical partner engagement is to develop trust with Medicaid members. How does Oregon facilitate so many engagements with stakeholders? How does it use the feedback from those sessions? And how does it gain the trust of Medicaid members?
Yes. So from what I understand, my staff is amazing. And I hope they're all watching right now. And I hope they watched the other parts and will correct me later if I messed anything up. But they, having the staff that is specifically focused on community engagement is so important. Not a lot of states have that engagement coordinator at the state level to really be working both with their managed care plan versions, whatever they may have, as well as directly with the communities. I am very excited and very blessed to be working in a state that prioritizes that community engagement. Oftentimes you'll see one person has community engagement and all media inquiries and all webinars and all of the things that is talking externally to anyone. But we really do have a team that works with a variety of different community members, regardless of whether it is specific to this 1115 waiver or other things that we want to be working with the community on, whether that be unwinding or a variety of other initiatives that we've got going on in the state. So having people in the different regions of the state that are focused on making sure that we are engaging with the community means that you do gain those relationships and that trust, rather than it just kind of coming down every 6-9 months, 6-9 years, depending on when, how often you are engaged in that particular community. But having that daily face of, a contact at the state is so important to gaining that trust and facilitating the involvement in our members. So often in the health equity world, we talk about the importance of making sure that member voices are at the table and are part of that conversation. And one thing that the CCO 2.0 back in 2020 set of reforms did was, while all CCOs were required to have what we call community advisory committees, those didn't have, they were sort of separate and apart from the community health assessments and community improvement plans. Now we're requiring that those community advisory committees are at the table for the development of those health assessments and improvement plans, so that they are part of that governance and that oversight of the health plans that they are working with, the CCOs, and that we get member voice in really all the activities of the that we do as an organization more broadly. And if that's not happening in any state that you are working with, I'm happy to help connect with the wonderful folks in Oregon.
Everybody, a round of applause for Emma, day 6.
Wow, thank you again, Emma, for those really insightful comments. It's very helpful as we embark on our waiver. So we are at the end of today, and I'm going to keep my remarks really short because it's been a long day, and a long day of like really stimulating information. And generally what happens with that is your brains kind of give out. So before your brains totally give out, let me start by thanking our sustaining sponsors, the Commonwealth Fund and Unite Us. Thank you so much again for your really impactful support to making this day possible. Let's give them a round of applause. And I also want to thank our other sponsors, Molina Healthcare, Accentra Health, IBM, NiceTech, and Equifax Carasoft for breakfast, lunch, and making other aspects of this conference successful today. So thank you for that. I'm also really excited to thank the UHF staff that really made today. Yeah. And I'm going to read their names quickly in alphabetical order, just so you get a sense of like how much it took to really make today possible. James Andrews, Denise Arzola, Giovanna Braganza, Alex Brandis, Adam Fifield, Amy Lynn, Anna Quinn, Emily Regis, Joey Rodriguez, Sally Rogers, Chad Shearer, Alexa Simonetti, Amanda Williams, and Sarah Wiley. Let's give them a round of applause. So, in my closing remarks, what I heard today was really inspiring. And what comes to mind is our state is about to embark on a really ambitious endeavor that's going to take all of us to make successful. Having been in government and now outside of government, I know that the best laid plans don't always come to fruition, but I feel like we are really privileged and fortunate to live in a state like New York where there is commitment to working collaboratively. And I look forward to that collaboration continuing. There are also sort of two things that stick out for me that Emma's remarks really sort of crystallize, that it's the concept of courage and respect. I think, Melinda and I started the day reminding us and grounding us on the fact that, it's the Medicaid member that's at the center of this. And I thought it was really important for Emma to remind us that we need to have respect for the courage that these members will show in disclosing their health-related social needs, and we can't take that for granted. I think it's also important for us to have respect for the courage it will take for all of us to work outside of our comfort zones, right? In many ways, what we are going to embark on in August, when all will be revealed, is going to be a new way of being. And so that not only takes courage and respect, but it also requires that we have grace with one another, because it's not all going to go smoothly. And we have to remember our collective focus on that goal of achieving health equity in New York State. So with that, I want to thank you for your attentiveness, for your incredible questions, and let's go forward and do this. Thank you.